Hi, John.
Okay, I'm unmuted here. Let me get
Now,
my headphones on, okay? Because I'm in a.
John, I'm sorry to ask you this, but I'm
I'm
in
in a,
the
I'm in a
hospital.
hold on, I'm in a cyber cafe. It's very noisy. Hold on.
Sorry, John.
Okay, I'm unmuted here.
Hi. So you can hear me now, John?
I can hear you. I'm just trying to make it a little more.
Okay. Oh,
Good. Can you hear me now?
yes, I can.
Hello? I can't hear you too well.
How are you, John? Sorry to disturb you.
Yeah, everything's good. Everything's
Good.
good.
So Ramesh confirmed that in 45 minutes he will be connected. So I need to pass the hosting to someone, just in case my internet connection gets over here. It's not.
Yeah,
It's quite weak indeed.
yeah,
So
and you have to connect from the hospital, right? Because
yeah,
that's a Zoom.
yeah. So the Zoom is now. This is the room. The YouTube is streaming online right now, and my plan is to send you the hosting. And once Ramesh is connected, you can get rid of that.
There's people here in the panel now. So
Not in the panel.
you don't know any of them?
No, it's only you and me in the panel. We have 6 attendees, but probably they will not be in.
Juan Miguel, Alman.
These are attendees.
Is he part of your team? Is he part of your team?
No, not yet.
Okay.
So that is fine with you.
I'll just wait. I understand. Someone has to stay connected.
I will leave the computer on just in case, but
Yeah,
as connection sometimes jumps and disappears, I'm
yeah,
scared of that. So I can make you co-host or host. What do you prefer?
that should work. That should work.
So now you are co-host,
Okay.
and you can do once Ramesh connects or any from the team. Ramesh is the one who is gonna be hosting this.
Yeah.
You can make him host,
Right.
and
Right.
you will get rid of that.
I know how to do it. And then
Thank
I
you.
have to leave after I turn him over to the host. I have to leave.
You have to leave in 1 hour, approx.
No, after he comes.
Okay. So I will just tell him that you are waiting for him.
Okay, I'll be here.
Thank you so much. I'm in a big debt with you. Thank you, John. Bye bye. Stay in touch. Let's speak later on. Thank you.
Okay.
Hey John, how you doing?
Hey, Dr. Caldwell, how you doing?
Good, good. Hey, do you have the schedule for this?
No, I don't. I'm just pinch hitting.
Okay,
Pablo went to the hospital. I guess his wife is delivering shortly.
okay,
Has delivered.
okay. Well, that's great. But yeah, I just don't know. I got sent this to sign on, but I
I
don't know
don't,
if yeah,
I don't know the schedule. Well, I
okay,
go by what's on the internet. Let me just go screen share with you in a second.
okay.
How are things in Utah?
Great, great. We got some beautiful spring weather.
It's, okay. It's March. There's no snow there, right?
Well, there's lots of snow in the mountains still, but there's no snow in the city. Yeah.
Okay, according to the schedule here. It's not, let me get another place. Okay, I'm gonna share the screen with you here. Okay, you see it?
Got it.
I'm sorry, I'm in a loud cyber cafe.
Yeah, yeah, no problem. That's good. So I just, yeah, that's why I said it said for me to sign on, but I don't see my name on there at all. So,
I imagine session one, Sergio, Giovanni, Bragi, Maldonado, Benez. When you're giving a presentation,
well, they sent me the link to sign on, so I don't know whether. Anyways, that's good because I've got a bunch of surgeries starting, so that's great.
I think you're scheduled to be a moderator in one, right? No?
Good. Okay. Terrific. Thanks, John. I appreciate it, buddy. Take care.
Four. Do not know.
Hi, everyone.
Hey, Dr. Kanan.
Hi, how are you?
Good, good.
I like the Florida behind you.
Yeah, well, I'm in a busy cyber cafe,
Oh,
but Pablo told me just to stay here until you got here.
yeah, because he is not there. He, he has the good news himself. He got a baby, Pablo, so he excused himself. And our meeting will start, we said, 2 GMT, which is still, I think, 40 minutes, isn't it?
Okay, I have to make you the host, but I'm trying to make you the host.
The host, we want to give it to Ramesh Nair, who's going to be with me chairing the session.
But I can't do it from my screen. I'm trying to make somebody else host so I
Okay.
can go. Let me see. How can we do that? I guess Pablo's the only guy that can change roles.
Okay,
to
I will
host.
I will give him a call and
Yeah,
ask
he has
him
to
to
change
do
the
the
role.
host.
He
Yeah,
has to change the host.
Oh, very good. Okay, very good. Jose,
He just needs
Jose
to change.
Ladeo, how are you? Brazilian time
Hi.
must be too early.
Oh, yes. It's now it's 10 o'clock, 10:20.
Okay, it's
10:20.
not bad. It's
It's
civilized.
okay. I'm waiting. Nice to see
What
you.
about you, John?
Mr.
John,
Professor
it's
Ben.
what time is you have now at home?
10:20. 10:20.
10:20.
10:20.
Okay, because you see,
Yes,
GMT,
more 40 times.
yeah.
11 o'clock in Rio.
I always think that I should give each country their local time, but it will be a lot of work. I said GMT, and they have to do the work, the calculation. So you were ahead that time.
That's okay. Worse is
Yeah, we can chat, no problem.
when
Yeah.
when the meeting
So
is in China, Tianjin, and sometimes this is a
very
very
good.
difficult time.
You know,
Okay.
Pablo, his wife just delivered a baby last night.
Oh, sure.
So, and I told him, stay with your wife is priority. Webinars come seconded. Okay, so Junior Pablo. And we have one speaker, his daughter has to, they called him from school to take care, Dr. Igor, so he won't be. But I think there will be few visitors coming from out. I think Armando Paso might contribute. He wants to have some in the discussion. It would be nice to have him. And we have, Gomez from Mexico. Yeah, he's an endoscopic surgeon. He is contributing as well. So we will hope we'll finish on time. There won't be any delay. Okay. Of course, we are waiting for service. Oh, here, this is Giovanni. Giovanni is looking, he's still muted. Giovanni. Unmute yourself. Unmute, Giovanni. You are still muted. You are still muted.
Now?
Now we hear the Italians, the baritone.
Very good.
Good to see you as well. So Giovanni, Pablo has apologized because he got the good news. Adriana got the young Pablo.
Wow, fantastic.
Last night, yeah. So
Fantastic.
we added one family member to the IANA. Okay.
Very good.
Very good, yeah.
Greetings to everybody.
Yeah, exactly.
The family, to the Pablo family.
Exactly, yeah.
Now, how can... Okay.
Okay, Dr. Kanan, I'm gonna go. You should be fine. You should be fine. Pablo's connected now. He's connected from the hospital and there's been no
Okay.
problem. Okay?
All right, wonderful. Thank you.
Yeah, you're connected. He doesn't have to change anything. He doesn't have to do
Okay.
anything. You don't have to have him do anything.
Okay.
Okay? So have a good
Wonderful.
one.
Thank you. Thank you. I appreciate.
Imad, we start at 3 o'clock?
Yeah, 3
Okay.
o'clock. I mean 3 o'clock your time.
Okay. Okay.
Yeah.
And close for a while and I will be back.
Okay. I see Keki. Where is Keki? Here, Keki. Keki.
Hello, can you hear me?
Now I hear you.
Yeah.
I like
So-
the pink shirt. It
Ah.
fits you very nice. Yeah.
Thank you,
Very
thank you.
Okay. How are you,
Uh,
Kiki?
Alhamdulillah, everything is fine. I just read the sad news about Fukushima.
Yeah, we just got the message just half an hour ago.
Yeah,
From the family, it seems they decided to keep silent about this for the time being.
Oh.
So we get the message to stay silent, and that's why we are staying silent. But
okay.
everybody knows about it, and the
Oh.
great loss. I'm sure it's a great loss.
Yeah, it is
Yeah.
unbelievable. I actually stayed with him for 10 days in his house in Akasuka,
Yeah,
Akakusa. I was a personal friend of mine.
yeah, me too. Because I was in the 90s, visited him, and when he was with the Kantuma Takakura. And
Yeah.
then we went to his private hospital owned by his relatives and
Yes,
saw
yes.
the procedure. He has been an innovative, marvelous
Very much so.
microsurgeon.
Very much so,
Yeah.
yeah.
Yeah. I want to ask you something, if
Yes.
this is a short notice. We have one cancellation of the presentation.
Oh,
Are you to step in or you prefer to stay only on the discussion?
but my computer guy who does all my work, he's no more over here. He's gone.
Oh, okay, no problem. So we will handle it differently.
Otherwise, I would have been very happy to do it.
No, I know,
We keep-
but
keep-
because Igor could not
Ah.
join, he just got me a message. His daughter at their school, they called him. He has to deal with her. So, and I told him, okay.
Okay.
And Pablo won't be here as well because as I said, we have a young Pablo.
Oh,
You heard this?
who is this young
Kiki.
Pablo?
We have a young Pablo delivered
you already-
yesterday.
Oh, wow.
Yesterday. So
I
I was talking, we have one family member increased of the IANA and Hakuna.
That is so
He will
nice.
be
to hear.
running after us when we are on the stick, walking like this.
I hope not. I
So
hope
he
not.
apologized, and I told him, fine, we will take care of that.
That is understandable. Yeah. So are we starting in the next few minutes or we have half an hour?
No, we will start at GMT 2 o'clock, which is, I think, I don't know what is the time
Half an
now.
hour
It's
from-
still
Half an hour
half
from
an
now,
hour
25
from now, I think. Yeah.
Yeah.
Let me check. Let me check in Mumbai what time it will be.
In Mumbai, it should be 7:30.
What is the time now? 7:30?
Now it is 5 to 7. No, it is 6:55.
6:55. So it's 7 we will start in Mumbai.
In 5 minutes.
No, in 30 minutes.
Okay.
30 minutes.
Okay.
Uh,
All right.
I saw shortly Vladimir disappeared again. I saw his face. Vlad is gone. When he heard half an hour, I think he said this too early for him. Yeah.
So can I join you in about 10 minutes? I can finish seeing one
Yeah,
patient.
no, take your time.
Yeah.
So
And
we'll have a half an hour.
But do we have a password? I'm seeing you from my phone. But if I have the passcode, then I will do it on my computer. On the Zoom.
You don't have the passcode? No, I
No.
will send it. I will send to you. Okay.
Oh, please. Okay, please. Okay, please. Thank you very
I will
much.
send it on the phone. You transfer it to your
Yeah. Okay,
computer.
perfect. Thank you. Thank you.
Hi, Ramesh.
Hi, Imad. How are you?
I'm fine. How are you?
Very good.
So we have to handle the situation today. There are a
few
few
absentees, I heard.
Yeah, I sent you a few changes happening.
Yes, yes.
You saw it, yeah.
Yeah, good to see you, Victor and Giovanni.
Hello,
Victor.
how are you, dear friends?
How are you?
Hi,
Now, this time is civilized time for your place in Mexico. It's 10 o'clock or?
Here is 7:14. 7:14.
Because
That's not too bad.
it used to be 5 o'clock in the morning when we start in the old days. Yeah. Yeah. Wonderful.
I saw this changes, Imad, that there may be some discussions which joining us.
Yeah, Luciano apologized because of the news. I think he is very close to our colleague as well, who deceased a week ago. We were not aware of it, but the family requested to be silent about it. Taka Fukushima has deceased a week ago. We were not aware, but I got the news today, and we got the message from the family and from the place where he's working that to keep silent about it. They don't want to announce it publicly at this moment. So I said, fine.
Sure. I think most of the groups have got messages about it, and so
Yeah, because when I heard about it, I have to put it to the group so they can express their condolences and things. But that's the wish of the family, and we kept following that wish. So Luciano won't be with us. He apologized, and we accept his apology. And Pablo, as I don't know whether you heard or not.
I heard. Yeah.
So we gave him a good reason.
Yeah.
And who's else? And Igor just called me. He has to
I
go
also
to the
heard.
school you heard about. So we are this. So we will handle between the discussions, and I think the time will be convenient for people to expedite, but to stick to their timing, and we'll fill the time with the discussion.
Yeah.
I mentioned to you, we have invitee for everybody, invitee from outside. They said they were interested to join in the discussion. We have Dr. Amador from Mexico. He is joining as well. He's a good endoscopic surgeon.
Yeah.
And Francesco, he said he has a procedure to finish. And once he finished, he would like to join the webinar. I mean, as a attending and perhaps discussion or comments.
Do you know about Keki coming? Or?
Keki is there. I saw him. He was there, and he will be on time.
Yeah.
So he will be among the discussion. Sebastian, I tried to message him, but he got the connection and the message ahead of time. I hope he will be on time as well.
Yeah. Yeah, I just asked Pablo to make me a host because I think I'm still not a host yet.
Yeah. I think he is trying, and I sent him again the message to make you the host.
Yeah.
So, Giovanni, are you prepared to Malaga?
Yes.
All right. So, Ramesh, are you coming to Malaga as well?
I am coming.
Okay.
I won't be there for the full conference, but probably 2 days I'll be there, and the last day I might skip.
Oh, I see. Yeah.
Me too. I have to go back at 9. We missed the last day because I have another commitment in Rome.
Okay.
So you have to go to Rome and then to Phoenix. And from there to Phoenix?
And after, pack and go to Phoenix.
Yeah, to Phoenix, yeah.
Yeah, I also haven't booked my tickets to Phoenix yet, but I'll have to do it.
Oh, I see. Must be a good meeting. See, the program was very well prepared.
Yeah, they haven't. I think I've been talking to ASME, and he's waiting for their response and some further clarification. So I'm waiting to hear back from ASME about the accommodation and everything.
Okay. Yeah, I saw Vladimir was earlier here, and then when he had still half an hour, he left, and he will be back.
Okay. So we have the 2 sessions with the three talks
Each.
each.
So the first session will be only 2 talks.
Yes.
Ego escape.
And we're going to keep the discussion at the very end of the whole.
I think so, because they are mixed together. It would be nice to have them at the end.
Okay.
If the speaker wants to leave early, then we might give a
That's the
discussion
main thing.
after
I
the
think
first session.
many of the speakers may want to just present and then may have something else. But we will
Yeah, so
find
what
out,
we
I
can
think.
do after the 2 talks, we can give a discussion
Yeah.
for the first session, and
Yeah.
then we give a discussion. And
Yeah.
then
I think
at
that
the end
makes
of the 2 sessions, we can be liberal with the
Yeah.
discussion if additional question came up.
Yeah.
Now, as long we still have time, aren't we?
Yeah, we've got 15 minutes.
15 minutes. While we are talking, I just want to share with you some initiative I'm planning for the IANA, which is the certificate of training in neuroanatomy fellowship. I'm initiating and I approach 5 centers, and 4 of them they express willingness and readiness to do. And we will start around July, September this year.
Yeah.
I think Igor will be the starting one of the centers. Abu Zur is another. Matthias Baldocchini, and I hope the Sebastian and Roy.
Yeah.
Pablo, he has to clarify things with his department, but he will be eventually joining. So there are 4 centers already, and the fellowship will be for young people under the age of 35 at the final years of their training, or young neurosurgeon, they are at the beginning of the career. We elected not to have them in the Asian group, so it would be difficult.
Yeah.
And sponsorship should be from their country or their institution.
Yeah.
And but what I called each center, I gave him the supervisor, IANA supervisor, IANA host director, to not to go conflict. Like Dr. Awuzeva mentioned to me, if I can put Igor, he is the director of the lab. I said, no, it's not a matter of leadership and things like that. It's a matter of liaison with the IANA. Who is running the show for IANA? He would be the IANA moderator for that center. Some of them, they are really the director of the lab. Some are not, but they are the one who will be liaison with them and lead the IANA collaboration. And the timing, minimum of 3 months, that can be expedited. Like Dr. Abuzov, can unmute yourself. Hi.
Hi, Abu, sir. Good to see you.
Hi.
Hi, how are you? You changed the look now. All right.
Yeah.
Okay. So he kindly said he has a point that 3 months is too little. Sometimes they want them to be part and then make research. So he expedited up to 6 or 12 months. Is the only. The others, they have it for 6 months. Matthias Baldocchini, he will have it for 6 months, and he's going to take as well candidate. Usually 1 to 2 candidates per year. And then at the end of their stay in the lab, which is for cost-free, this is the condition. They won't pay any money for the lab, but they have to be responsible about themselves, flight, accommodation, and the host might try to help them if they are potential. And I will try, everybody from us will try to find them, the candidate, some funding if they are coming from less privileged countries. The other condition we put, the lab should not take people from their own side, so not from the country. So Pablo, he cannot take from Spain. Abu Zur cannot take it from Turkey. He should take from other countries. So with this, there will be no biased opinion about the selection. And we have initiated a small committee to select the applicants and review the applicants. again, the people I put, they are not part of the lab leadership. So we put Landero, I put two others who are not part of the lab. I think Ramesh, you are one of them as well. Okay. And Igor will review with you and then submit it to be finalized, and we'll go from there. So it adds on to the mission of the IANA. We are having webinar, we have on-site, and it'd be nice to have this kind of training in the lab, because I think it's valuable. It's a white matter or skull base or vascular matter.
Yeah, I agree. I think it.
So, Dr. Abuzer, how is the situation with the Yashagil Academy? We are excited about it.
Yes, it's going well, and we are trying to finish the program. I think next month we will publish the last shape of the program, and
Very
also we are still accepting abstract.
Excellent.
Through registration for the young neurosurgeon whose abstract has been accepted.
Okay. Oh, very good.
When is it happening, Abusa?
In June, from 2nd to 6th. June.
2nd to 6th. So yeah, you haven't sent out the brochures yet, have you?
They sent the announcement there only.
Okay. I have a
Binzu, yeah.
Yeah.
So Binzu, hi. Unmute yourself.
You are muted.
You are muted.
Okay,
Now
Professor.
We can hear you.
Hi.
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 How are you?
Hi. Nice to see you. Hi.
Good to see you.
Fine.
Dr. Binzu, you have been very active in webinars. I've seen you in 2 or other webinars. Yeah. Very excellent. The Asian Congress and the Chinese West, very good. Excellent.
Thank you. Thank you.
It must be a bit late in China. What time is it there now?
Professor Nair, it's 10 o'clock, 10 p.m.
So, yeah. Thank you for coming.
Yeah.
Right. Tom is here.
Thomas, in the working suit. Tom.
He's still connecting.
Hi, everyone.
Hi, Vladimir.
Vladimir, I saw you earlier and then disappeared.
Hi, Tom.
Yeah. Abuzer, you got a serious look now.
Yes, a bit.
Much more responsible.
Thomas, you are unmute yourself, Thomas.
Oh, yeah. Thanks for reminding me there.
Okay.
Hello, everyone.
Hi, how are you?
Not too bad, not too bad. And you?
So what is the menu after this webinar? I see you are well dressed for the next attraction.
You mean me?
Yeah, what do you have a procedure
I'm
for
done.
next?
I'm done because
You're
I have scheduled cases that I don't have to be in the operating room in the afternoon otherwise.
later. Okay.
And otherwise I will miss it up again.
Yeah.
I'm done.
Okay. For all of you, just expect Pablo apologize for today. He has a good reason for the family.
Very good one.
And we all cheer him. And I said we added one additional member to the Hakuna and IANA.
So what's the name? What's the name?
Pablo Jr. Yeah. And
Pablito.
yeah. And Igor apologized. He has a family reason, a good reason. He just called me half an hour ago.
Igorito?
So he won't give a presentation, Igor. Okay. And same with Luciano Mastonandi apologized for being discussant. He has a good reason as well. And we said fine. Samer, oh, good to see you.
Good to see everyone.
Oh, he is as the starting procedure, not like Tom at the end of the procedure.
Sorry,
It probably just woke up, no?
Oh.
sorry, I'm between cases. I just finished the first case.
Oh, between the
Morning.
cases. Okay. Wonderful.
I'm yet to hear back from Pablo about shifting the host onto me, because I think maybe Pablo is traveling. I may need that access to share the. Let's see if. Yeah.
I'm not sure if some of you know about Pablo.
Yes,
but,
yes.
No, we
yeah.
know.
Yeah.
No, we expedited on this. We were saying he added one additional member of the IANA. Junior.
a junior member.
Yeah. Moody is with us.
Hey, Moody.
Hello, everyone.
Moody,
See
hi.
you all again.
Good afternoon.
Good afternoon.
see
Good afternoon. Hi, Thomas.
I
Hi.
can see, you know,
Hi.
admire the leopard in your office there.
Yeah. We have invited few colleagues, senior colleagues. They will join the webinar and they might contribute to the discussion on top of the discussant. We have Kiki Terrell is on the discussing panel. And we have Dr. Amador from Mexico. He's an endoscopic surgeon. He might contribute or give some comment. Armando Paso as well. And Francisco, he's finishing procedure and he will be attending. If we have the time for the discussion, they are most welcome. Anybody can be part of the discussion. So anybody has any additional information wants to add or comment?
Who's going to Phoenix?
There was one
Pablo,
question on Phoenix. Ramesh has a question.
I am coming, Vladimir.
Yeah.
Yeah, but I spoke to Asmi and he's still waiting for some more information back from the.
They are pretty slow, the Americans. There are three embassy suites in Phoenix area. They didn't tell into which hotel you should book. Probably the one downtown, most likely.
Well, as long as there is some.
We are expected 200 US fee for the Congress.
Yeah.
Everyone pays.
Yeah. So got Professor Takio Goto as well.
Takio, unmute yourself.
Oh,
hi,
good to see
Takio.
you.
Hi.
hi.
Good to see you.
Good to see you.
So apparently it is John Bennett is hosting currently. So I'm gonna call John and ask him to just make me the host.
John actually was earlier here. He did have some difficulty.
No, he's the one I think in that international. That John. John, are you there? Maybe.
No, he was there before I see you. He was here and he said he has some difficulty and he will talk to Pablo.
Sure.
And,
I think he's already there, but I just need to.
Hi, Miguel. Nice to see that you are online.
Miguel is
muted
and hidden.
Miguel, you're muted. At least to say hello.
Trying to join, probably.
Miguel is having siesta, I think.
Back to the siesta.
Now we can see you.
That certainly woke him up. Huh?
Sorry, I had some technical problems because the computer was having siesta, not me. How you doing, my friends?
Very good.
So you are dressed very warm, Miguel. You are dressed very warm. Is it that cold?
Well, not. It's winter here, not not very cold, but you know, I'm just 200 meters far from the seaside.
Oh,
so
okay.
With humidity, but the weather is nice and it's going to be warmer by May by the Spanish meeting.
Make sure you made the booking of the weather with the telephone.
I made all the application. Everything is done, and we are going to have a wonderful weather.
Well, if the temperature goes below 30 degrees, Miguel puts a jacket on straight away.
Well, now it's here. Maybe let me see. I think because I have the mobile here, maybe 20 something. Not
that's
20
cold. That's cold for Miguel.
It's very hot for me here.
Yeah. It's
Sebastian with us.
23.
Hi, Sebastian.
Hello.
Sebastian, my friend.
Everybody was
degrees.
concerned. Sebastian would be there. Said yes, he will be there. Yeah.
Okay.
I think,
yeah,
are we
I'm-
ready, Ramesh?
yeah, I'm hosting now, so we are good to go as soon as we are ready.
Yeah. Please proceed with the first session. Will be
Okay.
good talks.
Thank you, Matt. Without further delay, we will start the 10th IANA webinar. We are excited to have a new set of webinars after the restructuring and with the patronage of Imad and Vladimir and capable hands of Pablo, who cannot be here today. And I've got all my good friends on the panel. And we have got a significant number of registrations this time. So we'll start without first delay. We start the 2 sessions, and me and Prof. Imad Kanan will be moderating the first session. And the second session, and Pablo cannot be there, Abusa will be there, but we have further colleagues joining us.
We can cover, or somebody will cover,
Yes.
whoever is ready to read it.
The first session will have 2 talks, and the first one is by Prof. Giovanni Brogi on the retrosigmoid approach and the tips and tricks. This will be a good session given his vast experience, and to especially for all the younger neurosurgeons to learn from his experience. So Giovanni doesn't need any introduction, has been with us for all these years, and would like to invite Professor Giovanni Brogi to start his lecture.
Okay, thank you for this presentation. I will try to have the screen with you. You see it?
Yes.
Yeah, we see it. Can you make it a presentation? Yeah, that's right.
Okay.
Yeah, all good.
It's good?
Yeah.
Okay. So good afternoon or good evening for everybody. It depends from the site where you were and the young people that are following us. This is a kind of, let's say, remake the old style. There is also an error, is retro and non-rero sigmoid. And this is a kind of tribute also to our friend Taka that is going away. The presentation is coming from the whole group of Vesta, particularly Paolo Ferroli, Francesco Acerbi, Morgan Broger, and Brestelli. And let's go to the matter. The retrosigmoid approach is the approach that has to be used for all the cerebropontine angle pathology, and we will discuss about that. The anatomy, you see, I'm sorry. Okay. Let's take away this, because I have your face on the screen. Okay. And this is the approach, and we will discuss in which direction and which are the, let's say, the suggestion, let's call tips and tricks to go here. This is very important for young people and for people that are not accustomed to this kind of selection. Anatomical landmark. There are 3 landmarks very important. One is the mastoid trip, of course, here, and the asterion, that is a little depression that you can feel in your patient, is just above the just above the transverse venous sulcus. That is the most important things. The anatomical landmark you see here, that is very important for the people that are not accustomed. There is a line that is from the zygomatic arc to the asterion to the inion, and down here you have the mastoid tip, and you see here underline the 2 venous important structure, transverse sinus and sigmoid sinus, and that the reason why we call that retrosigmoid sinus is because it's below or back of the cross of the 2 sinus. This is the bone landmark, just to remember that when you feel touching the skull, touching the skin of your patient, mastoid the pterion, asterion, and so. But let's go to what you will find when you open. You see here that opening, making the incision. I will tell you later on how to make the incision. You have these three important landmarks: the asterion and the lambdoid structure. This is the structure that you can find in an opening, and you see here that this picture is coming from our friend. Bone landmark, you see here that this is a paper that is talking about the different surgical approach, and you see here that in majority of cases, in the large majority of cases, the venous structure was present in where you think that they have to be. When you open, and I will tell you how to do the craniotomy afterward. The craniotomy is a mini craniotomy. Sometimes for some pathology it's just a craniectomy, but we'll discuss later on. You will find the three important cranial nerves that is affected by this kind of pathology of the cerebrospinal angles. Trigeminal nerve, vestibular, auditory and facial complex, mixed nerve, glossopharyngeal, and vagal nerve. And we see also the lower nerves. And again, for what about the hearing, you see here the relation of the auditory nerve with the receptors that are in bone of the petrous bone. This is from our master Roton. You see here the different structure, and you have to remember for young people that from here to here you have 10-15 millimeters. Surgical position is very important. It's important for all kinds of surgery, and it's very important for this type of approach. You have two main approach. One is the lateral decubitus, and the other one is sitting or semi-sitting. You see here the lateral decubitus, that is so-called park bench. I think that is coming from a kind of closer sleeping. You see the Mayfield field is holding the head. And the most important things when you position this patient is to this arm, because you can stretch the nerves and the. Why, if you go to the sitting position or semi-sitting position, the head should be rotated, while here the head is parallel to the floor. Here the head is rotated on the opposite side of where you're working, and after you decide which and how long, how big should be the craniotomy. You see you have better. This is the positioning, and this is one of the approach that can be discussed. This is what is you can see in the operating room. You see here, this is a semi-sitting, this is a sitting position. It's very important that arms are positioned in a good way. The only things that is very, very important, and to be remembered, that when you position this patient, also in the park bench, the patient should not be curarized. Curaro is an enemy of this position, because you can easily stretch the neck of the patient, and in this case, you can have a hanging of the patient. So you have a disaster just before starting. So remember, as to the the anesthesiologist, but the anesthesiologist has to be very trained for the sitting position, not curarization. You see here the advantage of the let's see if I can move that. Okay, the advantage of this sitting. This one is semi-sitting. You see the feet are at the same level or higher of the head. That is something that is very proposed many times by Majid Sami, and all of us are trained on and trained our team of anesthesiologists to do that. The advantage of the total resection of the surgery is a little bit more when you use this one in comparison of the park bench or a lateral position. This position has one major disadvantage. It is the fatigue of the arm of the surgeon. So you have to be trained for that. You have support to have a position of your arm. Otherwise, after 2 hours, the physiological tremor may be increase of that. So this is a kind of possibility. In my experience, it's very, very good, this approach, but you have to be aware of what are the limits of this approach. Apart for the cardiovascular situation in which you have to be aware, and the anesthesiologists have to put the intraarterial catheter and so on and so on. Let's go ahead. Stop. Okay. Skin incision. Skin incision is very important. Why? Usually the patient that is undergo to this kind of surgery is the only things that is squaring is I have pain in my neck, I pain and around my ear. And that is very important, that the skin incision should be limited and should be and the surgeon should be aware of what is taking out or cutting out. The occipital nerve should be, of course, avoided, but you will see here that there are also some venous drainage, very important, the posterior auricular vein, the occipital artery, and you have to be aware of that. Don't sometimes you see immediately, some other time not. The other things is that you can be aware of the insertion of the different muscle, the occipital muscle, the sternocleidomastoidal muscle, and so when you cut that, you have to try to cut with the scissor and not with the monopolar coagulation, because that is making more pain afterward. And that is the crucial point. Sometimes you get bleeding immediately and you say, why I got there? Craniotomy, small hole, and depends on what is your experience or your attitude. You make a small bone flap, as here, that can be enlarged with the different types of rongeur. Closure, it depends of what kind of craniotomy you can make and what is the instrument. This is for a piezoelectric cutting, that is so. This is the reason why it's so square. And after you can close with MRI compatible plaquette. Dura opening. Everybody suggests, and I personally suggest, a kind of semilunar cutting, respecting the sinus, transverse sinus and sigmoid sinus, in such a way you can have space to get into the natural corridor that is the system in between the tentorium and the surface of cerebellum for what is concerned one type of pathology. If you ever to go down, as we see later on, you can use this one with the retractions of gravity. You can reach the auditory vestibular complex. While if you have to go to the glossopharyngeal nerve, the approach should be, the craniotomy should be a little bit lower, as we will see. This is very important. The four triangle, that is anatomical triangles. The superior one that is over the cranial, the trigeminal nerve, where you get many times the Dandy vein. This is in this way, but most often is in this way. The superior triangle in between trigeminal nerve and the auditory vestibular complex and facial complex. The inferior triangle that is below this complex nerve situation, and the inferior one, and that is below the vagal nerve and the glossopharyngeal nerve to reach the lower cranial nerve. So you have to be aware where is your pathology and which will be the anatomical situation that you will encounter to reach your pathology. And that is making the decision how to where to make the craniotomy. It depends if you are working and try to reach this kind of nerve, third, fourth, fifth nerve, that the craniotomy should be nearby the angle in between the two sinus. If you have to go a little bit lower, 8 and 9, the craniotomy should be, as you see here, a little bit more, not more lateral, but lower of transverse sinus, and you can reach here, position the pitch in such a way that the gravity allow you to reach without the cerebellar retraction. And that is for the lower cranial nerve when you have to go to the 11 and 12 nerve, and also sometimes with the 10 nerve, and to reach here in a very, let's say, simple situation. Position of the patient, as you see here, the patient in this case is affected by trigeminal neuralgia, is supine, and this is you can, following the landmark that I showed you before, zygomatic heart, mastoid tip, inion, you can design your venous sinus and make the incision in such a way that you can plane your craniotomy in this way, a little bit lower of the asterion. What you will find, the conflict can be very pronounced, as in this case, or less pronounced as in the other case. The only problem is that to use always a sharp dissection, not do any traction, and at the end you can put what you desire, muscle or tabotan to take away the artery from the nerve. A venous drainage, small venous drainage, can be coagulated if it's crossing the nerve, and the only thing is that should be avoided to damage the petrous vein or Dandy's vein, as you call it. You hear a different approach for the 9 nerves, so glossopharyngeal nerve, and in this case, you have to remember that the choroid plexus is playing a very important role, and many times is responsible for of the neuralgia, of the compression of the nerve, without having the artery too much responsibility. The artery is the pica here, while for the auditory vestibular it will be ICA, and as I showed you before, the supracerebellar. Let's see one change, if a change of the retrosigmoid approach, if you needed to go in the lateral situation, and this is a kind of extended approach. You see, let's say, you see here the lesion, and the craniotomy is done in such a way that you pass through the superior part of the cerebellum. For the question of time, I'm going a little bit faster. Sharp dissection, sharp dissection. Gravity is taking down the cerebellum and opening the space to work in a quite comfortable way. This case was done in a semi-sitting position. You see here the trochlear nerve. And let's go ahead. And now, when you expose the lesion, you can gently take it out or sucking out. Is very important suggestion not to use the ultrasound aspirator, because as you see, ultrasound aspirator is very dangerous for the small arteries, and as you see here, all the surgery is, let's say, without blood defects, and that's to go to the end. And at the end, of course, you can make stimulation of the nerve just to learn what you are exposed to. Let's go ahead. Problem of sacrifice of venous pectoral vein or Dendy's vein. All the literature is saying that is better to preserve because you don't know how many venous drainages are coming from the cerebellum and from the pontine angles. So I think that first, primum non nuocere, so try to preserve this vein. If you are in trouble because the vein is just crossing your way to reach trigeminal nerve or other nerve structure, you have a kind of help using the ICG video angiography. You see here the situation. This is the vein. You can use the flow rate under, it depends on the microscope that you have, or the ICG. And one suggestion is that you can always, when you are very uncertain of what to do, you can put a temporary clip on this big vein and see if some other drainage are coming out. And so in this way, you can sacrifice the vein. If they are not coming out, it's very dangerous if you cut or damage this vein. So this is a kind of trick that the technology, modern is 15 years that is around. Technology can be used, and all the major microscopes that are using, I'm not making any brand comment, give to you this possibility. Again, the question, microscope or esoscope or endoscope? I will take out the esoscope because I think for this kind of approach in which the craniotomy is very small, esoscope is making a lot of difficulties more than advantage. Microscope is, in my opinion, is the best because of the field and three-dimensional field. Endoscope is it can be used. The only thing is that, as Sebastian probably will tell us, it depends of a very good training because you have only two-dimensional situation, and it is your hand that is making the third dimension with the visualization. And of course, you can, using the different triangles, you can go up of the tentorium and down till the foramen magnum to take out or to make a correction of your type of pathology. Again, remember these three very good images of Roton. It depends on where you want to go. In this situation, this is the geminal nerve complex of 8 and 7 and 8 nerve. And remember, if you go around here, that there is the choroid structure that is really taking out the vision, and you can easily coagulate that. Different arteries, superior cerebral artery here, ICA and PICA down here. In conclusion, the approach that I try to show you today is very important. I think this is the kind of gold standard to go to cerebropontine angle pathology, both for tumors and for functional disease of cranial nerve. It can be performed in different positions. It depends mainly of what is your team, park bench, supine, semi-sitting and sitting, and you have to decide it with the head of your team. And as I say, require a competent team, competent about your assistant, and the anesthesiologist a really very important role in position the patient from park bench to sitting position. And remember, no courier because it's dangerous. Thank you very much for your attention, and this for the young neurosurgeon. Be aware when you look at the mirror. Thank you.
Thank you. Thank you, Prof. Ambrogi. I think we will have a discussion at the end of the next talk. So please stay with us, and I'm sure there'll be lots of questions, even though this is a traditional approach and workhorse for most of the operations we do in the posterior fossa. I'm going to invite my dear friend, Professor Vladimir Benish, to talk on the tilovelar approach or the enough lateral approach. I think Vladimir is talking about.
Enough. Yeah.
Yeah.
Well, let me share the screen.
Yeah, we can see. Can you make it? Yeah.
Do you?
Yeah.
All right. Hello, everyone. It's a pleasure to be here, and it's always nice to be among the friends from IANA and other friends. I'm going to talk on what I call enough lateral, enough teloveral. And this is a tribute to Juha Hernesniemi, who called the far lateral enough lateral, because you can customize and you resect the condyle only as much as needed. And the same, since inherent part of all these procedures is mobilization of the tonsil. Tonsil may be mobilized either from lateral or from medial or the whole, or nearly not at all. So I call this enough teloveral. And this is a combination which is very useful and very flexible, and may be used in almost any surgery in CC junction. I would like to start by welcoming our new IANA member, little Pablito Gonzalez, who was born today, I guess, in the morning, and I hope that he will be doing well as whole the family. And congratulations to Pablo. This is probably his best achievement, among others. So this is also from Alicante, from Pablo's lab, what we did there along with Roy Daniels. This is the approach. You come from lateral, you see the cerebellum, you see the brainstem, up the spinal cord, and of course, regularly the approach is much, much smaller, but this is nice to overlook. There are a few features not to forget. You get this triangle. Giovanni was talking about the up one, but we are even lower now, and the triangle is between the 9 and 10s, 12s and 11s, which gives you some space to work directly in front of the brainstem. And these nerves are also the important landmark during the surgery. Next feature is that one should not forget that the 12th nerve usually enters dura in several bundles. So once you find one bundle, it doesn't mean you have the whole 12th nerve. Everyone has to check for others. And then from anterior, this is from our lab, you are working in cerebellomedullary system, of course, cerebellopontine sometimes, in anterior spinal system, and in medullary system. And the most important structure over here probably is the anterior spinal cord artery, which should be preserved at all costs. So we have 4 kinds of lesion which may be approved by this same craniotomy. Extraaxial space-occupying lesions like meningiomas or cholesteatomas. Extraaxial space not occupying lesions, those are the aneurysms, mostly pica or vertebral junction. Then intraaxial lesions with exophytic growth, those are mostly ependymomas. And intraaxial, which do not move, cavernomas. In A and C, the lesion provides the space, and these lesions definitely are easier than the other 2. The position is exactly the same. Patient is fine, and we come from the head, either microscope or exoscope. I find exoscope a little more flexible since you get better angles of viewing, especially if you want to get as high up as the aqueductus, then the exoscope gives you much more comfort and much better line of view. Surgical chair in my hands is a must unit. It's like car driving. So enough lateral means condyle resection is customized, and we resect less and less of the condyle since the job can be done above and below the condyle. The condyle really doesn't hinder your approach except for some exceptions. Occipital, and that's probably the most important part, it should be flushed with the skull base and up along the sigmoid sinus if needed. But the bottom of the posterior fossa really should be drilled as much as possible. In afteroval, it again, tonsil is mobilized only we need. It, of course, can be mobilized as far as foramen Luschke and see how the dorsolateral aspect of the brainstem. And in certain cases, you may need a bilateral approach, like ependymomas of the 4th ventricle, cholesteatomas, and these. So that's all just, let's say, variation of the same thing. So let's start with extraaxial space is provided with the lesion. Those are meningiomas, cholesteatomas, plexus papillomas. And here is the line of vision. You see that you can come from above the lesion, from below the lesion. The condyle is just in the middle, and you can do your job without any difficulty with the condyle left in place. The resection does not need to be as extensive as in this case. This is a typical CC junction meningioma. And this is during surgery. First is, of course, the 11th. Here is the tumor. Then you would like to find the vertebral artery, which is another important structure over here. And you first surround the enemy before attacking. So it means going from downwards, all with the monitoring, all with the stimulation. Let's speed it up. Now we are above the tumor and we have the same 11th nerve here. And you see that in this, the tonsil does not need to be mobilized nearly at all, just at its bottom. Decrease the size of the enemy. Here we have the vertebral artery. Quite a lot of these tumors have the origin in between the vertebral artery and the 12th, and the 12th is probably the most difficult structure since it's in front of the tumor. Here the tumor already decreased, and from below the vertebral artery, pieces are taken out. This was one of the very rare tumors where there was in one tiny spot no dissection plane between the brainstem and the tumor. You see the 11th nerve, which already is dissected free. And now we get to the bottom, where is the 12th over here, and the remnants of the tumor are resected, and this is the final view, vertebral artery 12th tumor origin over here. And you see the space which this approach really gives you and which the tumor gives you. And you see the condyle is nearly not resected at all. So these are the meningiomas, plexus papilloma like this one before and after resection. And it was exactly the same in this case. It was needed to dissect the tonsil as high up as foramen Luschke, since the tumor was within the fourth ventricle and in the CP angle. So I started with the CP angle portion of the tumor. Now we are already done with that. And then from the fourth ventricle, where there was part of the tumor, and you approach the fourth ventricle from the lateral side, you see the tonsil mobilized. And here we are within the fourth ventricle, again resecting the tumor as far as foramen Luschke. And then the remaining piece of the tumor is resected again from CP angle. And it is really very flexible. In this case, the tonsil was dissected completely free. You see that the condyle was not resected, only to the level of the spinal canal, not anymore. This is after. This is another plexus papilloma, which is more medially, so the tonsil was dissected free from the medial side only to get into the fourth ventricle and to the dorsolateral aspect of the brainstem. And again, condyle in this case was not resected at all. It's still here in place. This is the 12th, this is the pica. Again, the same thing. Extra-axial, which do not provide the space, those are the aneurysms, mostly pica. This is the case where patient came in a very severe condition, Glasgow, 4, and you see lots of blood in the fourth ventricle, and I believe these are the surgical cases, since you remove the blood from the fourth ventricle and you speed up the recovery of patients, which you never can achieve with endovascular procedure. In this case, a little more of condyle is resected, and then we go inside the dura. This is here the aneurysm. The vertebra is coming towards us and going medially. This is the pica which is involved. The aneurysm is clipped, and this is the beauty of the approach. You just mobilize the tonsil a bit, and you remove whole blood from the fourth ventricle, thus reconstructing the CSF pathway, and I believe this speeds up the recovery. This is after surgery, the day after. Still some blood left, but the fourth ventricle is completely clean. The aneurysm is excluded. This is probably where most of the resection, bone resection is necessary. This is the old case, and I can tell you I would never dare offering surgery to such a patient. We do this endovascularly now, but in this case, really the condyle needs to be resected a lot. The tonsil again must be lifted from the lateral side and then going to this aneurysm of the vertebral junction. This is after surgery. But again, this would be endovascular case now. Intra-axial lesion with exophytic growth, it's like meningiomas, the same thing. The space is provided. As you resect the lesion, you get enough space for anything. Those are ependymiomas like this one, before and after, or such a low-grade glioma, which is going from C1-2 up into the cerebral peduncle. And this is the approach. You see the condyle is just resected to the level of the spinal canal. And starting from below, this is the part of the tumor which is in the cervical canal, going higher up, developing the plane of dissection. You see here, just gaining space by decreasing the size of the tumor, and suddenly there's space enough. This is the plane of dissection between the brainstem and the tumor, which is lateral. Again, we later on get into the fourth ventricle, and again you get there from the lateral side. This is the fourth ventricle. The tonsil is mobilized almost as far as foramen Luschke to gain enough entry into the fourth ventricle. This is seen here. You see the brainstem, you see the floor of the fourth ventricle. Somewhere here is the foramen lusca, and the tonsil is moved upwards, and space provided by the lesion is sufficient for any maneuvers. Of course, that was a piece of the tumor left behind. This is 5 or 6 years after surgery. The piece in the cerebral peduncle is left behind since I didn't want to harm the patient. And the lady is now like 30, 32 years old, having 2 healthy children born after the surgery, and the tumor remnant is stable over the years. Here is a hemangioblastoma in the same region. Again, the hemangioma provides the space. This was pretty difficult surgery, but still, here we are after surgery, and the patient is doing rather well, despite the fact that after the surgery there was a lesion of the cranial nerves, which improved over the ensuing months. The last group are intra-axial lesions where space is not provided. Those are cavernomas and gliomas of the brainstem. So here is the cavernoma, lower on-time cavernoma. The approach is again the same. The cavernoma gets to the surface under the 9th and 11th. And here we have the approach. This is probably the most important part, the skull-base resection as far down as possible. The condyle does not need to be resected, again, just to get enough of the approach. And this is after the surgery. This is another cavernoma in this region, is within the cerebral peduncle. So we mobilize the whole tonsil as far as foramen lusca to get the whole dorsolateral aspect of the brainstem, the same approach. Then arachnoid dissection, which is necessary as wide as needed and as possible. And here we are on the lateral aspect of the brainstem, and this is the fourth ventricle, and with the use of stimulation, we found the best entry point for the cavernoma, and this is the cavernoma resection. Oops. And this is after the day after surgery. You see that the cavernoma is out. This is the bony resection. So summarize, its skin incision is either straight or curved, mostly straight. The muscles are moved more medially since the lateral slope of the muscles gives you the angle of approach as well as necessary drilling. You do not need to drill the condyle more than the slope of the muscles gives you. So that's exactly the line of your vision if you want to get in front of the brainstem. T1 is laminectomy or hemilaminectomy. I prefer laminectomy since I want to control the opposite side, and it also gives you a better angle of view to the lateral side of the spinal canal. It means to the entry point of the hypoglossal nerve. Condyle resection to reach the vertical line, that's it, to reach the hypoglossal canal from medial side. Posterior face fossa base drilling flush with the skull base as much lateral as needed and along the sigmoid sinus. And this is probably the crucial part, because then you see well where the tonsil is attached to the brainstem on its lateral side. Medially, this is easy since we go around choroid. We do not transpose vertebral artery. It was a very, very distant path when I really transposed it. VA entry point is limitor drilling for me. As I said, work can be done above and below the condyle, which gives you ample space. Jugular foramen, hypoglossal canal, internal acousticus meatus are the most important landmarks and areas to control. Tonsil dissected as needed. The higher the lesion, the more telovelar approach. It means that the higher the lesion, let's say in cerebral peduncle, the more tonsil must be dissected free and moved upwards. And you can either dissect tonsil from medial, from the fourth ventricle, or from lateral, from CPA, or both, of course. So to conclude, it's standard yet customized approach. It's really addresses plethora of variable lesions. It's really working horse of CC junction for me. And you the approach to the lesion, not vice versa. It's not dogmatic. You really are going to resect or treat the lesion. You are not going there for the approach. Thank you very much.
Thank you. Thank you, Vladimir. We will open this for discussion. I have seen Prof. Keke Turel and Prof. Tom Sandharius online. So we'll start with some comments from both Keke Turel and Tom. Keke, Tom, you want to start first?
Yes, no, thank you very much. It was both very enjoyable talks. I myself spending quite a lot of time in the area that Vladimir described. I completely agree. I use this sort of approach quite a lot. It is good to have a name for it now, and it's also quite a sexy name. So we'll all be using it from now on. And also, for example, I don't like certain terms fundamentally, like minimally invasive. I just don't like, because essentially whatever we do should be minimally invasive, but sufficient to do whatever we want to do safely. And the enough word, pretty much in one word, captures both terms. And similarly, in the talk by Professor Brogi, the same thing. It's a systematic extension of a simple retrosigmoid approach as required, and that's the key thing. And that's again brings us back to the very reason why we have even IANA, is because we want to understand anatomy, understand the basics, and then customizingly develop very individual approach to very individual lesion that we're dealing with, rather than following some cookbook, with steps that somebody described in principle on a normal cadaver.
Tom, I fully agree. Thank you for your comment. I cannot express more how I agree with you about the minimal invasivity. I don't like the term at all, because should I have a big surgery in front of me, I would like to have a surgeon who is not talking about the minimally invasive approach, but the surgeon who would be minimally invasive in relation to the lesion. That's important to me. Not really the size of craniotomy or length of skin incision. The minimal invasivity, in my mind, means how you behave in front of the lesion and to the lesion itself.
And there's a hierarchy of things what matters, right? And you want to be maximally safe what maximally matters.
Exactly.
Which is, for example, a meningioma and PIA of the brainstem interface. When it's fused there, and if you struggle to see it, when you struggle to control it, then never mind whatever incision you made, right?
Exactly.
Thank you. Keke?
Yeah, so I think, okay, we first had Dr. Brogi. Giovanni, hi. So there are so many issues that you can talk about in retrosigmoid, right from the position. Hi, Eva. From the position. So most people today do not prefer sitting position, though we have been trained by the Sami school and we prefer sitting, but most people prefer in the world a lateral decubitus, or what we call a spark bench position. And one of the great disadvantages of sitting position is air embolism, and not everybody is able to handle it quite safely or even equipped to handle it. So, and this can start, the air embolism can start even from an emissary dural sinus, emissary vein, even before you go to the transverse sigmoid sinus or petrosal vein. So, also the point of craniotomy versus craniectomy. I know still many people who, to be on the safe side, choose to do craniectomy, what we used to do in the olden times, rather than do a craniotomy because that might sometimes land up in tearing the sinus. So many people choose to adopt a safer approach by making a burrow and then going straight towards the first bites will be in the direction of the two sinuses so that you don't go unnecessarily medially. So craniectomy, and then you can replace that bone defect with Pelacos or something like that. Whereas those would, but there was a opinion that if you can replace the bone, either by methyl acrylate or by the bone itself, then you have less chance of post-operative headache. There are many patients with CP angle lesion whose main complication is headache. They don't talk about craniopaths, but they all talk about headache, a very large number of them. So this is with regard to craniotomy and craniectomy. And dural incision also, you said something like a semilunar incision, which is quite good, but your diagram showed something different. Your semilunar incision should go along the sinuses and it will expose the cerebellum. But the way you showed your picture, the picture appeared to cut as if it was protecting the cerebellum and exposing the sinus. I don't know if I've seen it correctly, but whatever it is, the incision is a C-shaped incision which goes along the transverse and sigmoid sinuses, and then it goes down. Petrosal vein, you stressed a great important point. I know it is not at all a good idea, and I think the whole world agrees that you should at all costs try and preserve petrosal vein. And yet, there are many people who are not so patient to handle the, let us say, the trigeminal neurovascular conflict without hurting the petrosal vein, or sometimes they might just want to coagulate to make the job a little faster. But I think at all costs, petrosal vein should be preserved. I'm not very sure if this ICG that you showed is a good enough way to know whether the cerebellar drainage will occur by a particular petrosal vein which you intend to sacrifice. So, yes. So there are, n number of issues with regard to retrosigmoid approach, and we can keep on discussing it.
Yeah.
But if you want to make some comments, Brogi, you can do that.
Yeah. Can you unmute, Giovanni? Unmute. Sorry.
Okay, may I answer to Keki? Okay, Keki, thanks for your comment and your criticism. I think they are quite very important. First of all, air embolism. Air embolism you can have also in supine position. So I think that more you change the level in between where you're making surgery and the heart, you have more possibility to have air embolism. But if the team of the anesthesiologist is putting the Schwanz catheter, and with the Schwanz catheter, he can, and with the Doppler, he can recognize immediately air embolism, and you can fix that. From the and so the positioning is most important where you are training. That's it. In Milan at best, we do around 200 sitting position every year. So not myself, but all the others, and we are accustomed to that. But I understand that in other places it's difficult to accept that. And remember that Bob Spetzer was saying, I don't use in sitting position because I get tired. That can be one of the reasons. Craniotomy versus craniectomy. Well, of course, craniotomy is always better because you replace the bone. I don't think that craniotomy versus craniectomy is the reason why the patient have the headache. Patients usually have the headache because of this massive incision. That is the most important thing. And I say that it's better to use the scalpel instead of the monopolar to cut the muscle. About the question that was discussed before by Thomas, minimal invasive. Of course, today everything is minimal, except the car in our street, everything is minimal. And I think that is a word that is in the general knowledge of the patient. The patient asks for minimal, and you say, yes, we do minimal. But I agree with you that it's much better to have minimal aggression than minimal incision or craniotomy or craniectomy. The opening of the dura, yes, in the picture that I show you is the flap is on the other side of the sinus. I think that you can use it whenever you want. The best thing is to see the sign, the margin of the sinus. And this is the reason why some surgeons are using craniectomy, because they are afraid of using the bone scalpel. And when you use the Carison to enlarge your borehole, they feel they are really safer than using the cutting of the bone. Last things, petrol vein. You don't think that the ICG is useful? Keki, use it, try it, and you will see that it's not the solution, but it's helping you to decide if you can stretch it or not, or if you're closing, you wait for the complication. So in this way, I can come to you and say that I have a complication.
Thanks very much. Iman?
Yeah, going back to craniectomy and craniotomy, I don't think in the past 12 or 15 years I have ever done craniectomy for a tumor case of for CP angle schwannoma or these things. I do it for trauma, for massive swelling of the cerebellum, these cases, because you see the borehole, the way you put the borehole is important. I don't insist on exposing the whole sinus. For these lesions, nowadays, if you release the CSF from the cisterna, you decompress the tumor, that 4 millimeter you add it for the exposure, it's already given to you by the release of CSF and by decompressing of this tumor. So you will be flush with the tentorium without exposing the full sinus. And what I do, I make the borehole, especially the sequence of the borehole. This is very important for young generation. The first one, I put it in the lower posterior fossa area. You don't have risk of the sinus or vessels or any major structure. Then the last one I put is under the astrium, not over the astrium, because the astrium is the junction. If you get into bleeding, you damage 2 sinuses, and you should avoid this one. I do it few millimeter below, and then I have the dura open, and then I can use the drill finally to the edge to see the edge of the sinus. So you don't need to see the sinus from the beginning of the flap. And this is how I do it with all these craniotomies, and never have problem with the sinus with this technique. And now all my fellows do it the same way. I think this is very important to take in consideration. A tumor decompression give you space, give you relaxation, and your position. You are doing in sitting position that give you an ample of space between the tentorium and the cerebellum. So why you should expose the sinus in full to see the sinus? This is in the old days. I think nowadays you can try to avoid it, except the situation I mentioned.
Yeah.
Trauma, hematomas, and swelling cerebellum.
Yeah, thanks, Imad. I think you touched upon an important point, how to avoid damaging the sinus. I'll come back to you, Giovanni, but just one point I wanted to add, especially for all the panelists. If you have inadvertently entered the sinus or damaged the sinus, how do you manage it? I think it's important for our juniors to know what can you do and how to solve the situation. Because you hear about horror stories, people cutting with the craniotome through the sinus and causing massive problems. So could you tell us what would you do?
Yeah. Well, first of all, I would. Yeah, sorry, Karen.
Carry on.
Do you want give? We want to talk to you.
Please go ahead, Signores a priores.
Okay, thank you. First, other comment. I completely agree with Imad. Of course, you know, for teaching reason, I say expose the sinus, but it depends on the pathology that you have. If you have to have cranial nerve disease, functional disease, you have to expose it. If you have a tumor, it's not necessary because the tumor is making the space. The only thing is very important. I never use spine CSF subtraction. I think that you are right. You open the cisterna, and the CSF is making the space. About the damage of the sinus. Well, if the sinus is exposed, you can suture the sinus if the lesion is linear and is due to the border. Otherwise, you have to use the surgical or other situation. Now with the hemostatic, new hemostatic like FlowSeal or Surgicel or the other one, anyhow, you can manage with the kid of the on the river. You push and you stay and wait till it stops. But I think the most important thing is that you have to know that you can suture the margin of the sinus if that happens. If you make a hole into the sinus, that you cannot suture because there is no enough structure to be sutured. You have to just put some Tabotan, FlowSeal, and wait for stopping the bleeding. That is my experience.
Yeah, thank you.
Thomas.
Yeah.
Hemoclips are useful sometimes.
What's that?
Sorry?
Hemoclips are useful
Hemoclip.
sometimes.
I think when you have a sharp cut, especially while you're extending the dura, then it's obvious you can suture it or use the liger clip. When you have a torn out dura from the perforator or something, it's difficult. But the important thing I would say that it's important not to push so many things into the sinus or like gel foam or whatever and occlude the sinus, which is not the best way to treat it. Ideally, you should have a layer on the top of the sinus. There are a few products which are available which you can use rather than trying to push things in. Tom?
Yeah, so maybe I'll start with this one. It's good to have lots of different tools to your disposal, the techniques, because every tear is going to be different. Every context of the sinus is going to be different. And first of all, I would suggest, with certain exceptions, be very careful using craniotome over sinuses. If you have the dura stripped of the bone nicely all the way through and you're fully under control, yes, but be very careful because you can make considerably big hole doing this. Sometimes drilling along the sinus with suitable drill is better. Second, pretty much what people said with the biological agents, you have to be quite careful. And in fact, I don't generally use biological agents, this meaning like FlowSeal and Surgiflow and so on, over the sinus. Well, certainly I wouldn't instill it under pressure into it because you can end up with way more of the agent in the sinus and it can block your sinus and cause complete thrombosis. Because also the sinuses come in different shapes. It can be fairly wide where you are and downstream across C1, for example, between C1 and styloid process and so on, it can be very narrow and it can settle down there and you have big plaque and completely occluded sinus and all the consequences that come with it. Suturing is very good, but sometimes the dura can be super thin. So by trying to suture it, you can make a bigger hole than you started. So you need to be sensible. All the techniques that we are mentioning here are suitable for certain cases, but not for other cases. What we must not forget is also physiology. Sometimes just simply elevating the head and titrating the flow of blood from the sinus with simple gel form compression, maybe just enough for stemming the bleeding and the coagulation to happen. So yeah, lots of tools for your disposal, thinking of both physiology, anatomy, and so on is helpful.
Thanks very much, Tom. Imad?
I just want to point to a point that my dear friend Vladimir always say the best invention ever is the lumbar drain, and why that guy has the bad name. I think the way you drain the lumbar drain, this is very important, and the timing. You see, sometimes if you don't drain it and you open the dura, the whole cerebellum jump on you, and it will be like a strangulated hernia, and you have to start resecting. Where I put the drain, I don't drain, and I take the bone flap and I feel the dura and elevate the head. If it's still tense, I drain a 5 cc. It makes all the difference because the access to the cistern at this moment is difficult. If you drain 5 cc from the lumbar drain and close it, then you can open the dura to access the cisterna magna or the lower CP angle cistern and really. This is how I use the lumbar drain. But to say lumbar drain is no, I don't think is appropriate. I'm using it in most of these big tumors when the area is very crowded.
Thank you.
I will say a word about this. Ramesh, you know that, and Imad mentioned that, I really think that the lumbar drainage is the biggest invention in neurosurgery. We do all supra-infra and all retrosic in sitting positions, probably the same frequency as Johnny. If you release 20 cc in supra-infra, 20 cc via lumbar drain, you open dura along the sinus in order not to get prolapsed cerebellum, as Imad mentioned, and you immediately see your ambient system and mesencephalon without anything else. You immediately see incisura.
Yeah.
So why not drain 20 cc? Yeah. It's you do not need to touch the cerebellum at all.
Yeah. Okay. Thank you. And got Prof. Qureshi hand up. Moody, you want to say something?
Just a small note. I mean, an interesting discussion about the torn sinus, tear in the sinus. Of all the various things that were added, I tend to rely on a lip of dura. When I'm opening the dura, I tend to leave a little bit of a margin of dura, which can be retracted fairly safely. But also, when all hell breaks loose and you've tried everything, a stitch which can then be hitched onto the pericranium seems to do the trick fairly well after you've layered the things onto the sinus. So I usually have at least about 3 to 4 millimeters of a lip of dura when I'm doing the dural opening, because that comes in handy when you do need to tack the dura onto the pericranium, just like we do for extradurals. So just a small point which I thought I might want to add.
Thanks, Moody. And Imad?
I just want to get Sebastian and Miguel involved. They are doing a lot of complex posterior fossa and skull-based approaches. What is your thinking about that discussion, about the sinus? You would like to expose the sinus completely, you are exposed to the edge, and about the lumbar drain. Do you use lumbar drain or not at all, or on occasion?
Sebastian?
Sebastian, start with then Miguel.
Well, for the sinus, I have to say, if it's not needed, I don't like to expose the sinus.
Yeah.
Definitely for retro-6, the blue line is enough. Neuronavigation is great for this. I think it's one of the best adjunction of neuronavigation for retro-6 craniotomy is to draw the sinus before and to avoid exposing too much the sinus. We do quite a large number of combined petrosal, and we have 10% of thrombosis of the sinus, even if nothing happened with the sinus. So yes, it's very sensitive to thrombosis. It was never symptomatic in the cases we had. I think because the sinus would thrombose are also the sinuses who can thrombose, but that's just an hypothesis. About the lumbar drain, completely agrees that why not draining CSF before to avoid any manipulation of the cerebellum. We use it in preparation of some approach, or we drain CSF with a small retrosig incision in case of petroclival, for example, because I have to say we are quite used of getting CSF very rapidly in the lower cranial nerve cistern. But lumbar drain for this is definitely a good option, or at least taking CSF out with a lumbar puncture, 20, 30 cc's, depending on the situation. Completely agree with this.
Thank you. Miguel?
Thank you very much. Well, in regard to the sinus, what I do usually is just to expose, at least to insinuate the view of the sigmoid sinus, because I gather the best approach for CP angle is having the most possible lateral approach. So I try to expose that, just, of course, a little bit. And in regard to this is what I do always. In regard to the spinal drainage, irrespective of the size of the lesion, I think that opening the cerebellomedullary cistern is enough to drain CSF leakage, and little by little you are going to have the needed exposure. But I do not use spinal drainage. I try to do a very meticulous closure using, let's say, tissues in vicinity, try to avoid any leak and have a watertight closure. But this is true that people using CSF, perioperative CSF drainage, have less incidence of cerebrospinal fluid. And this is my understanding regarding that.
Thank you. Thank you.
I have one more. It's a nice discussion, and that's why we are triggering more as it goes. To Sebastian, it was very interesting. I have the same experience with doing the posterior fossa, and then the radiology report comes, there is a sinus thrombosis, okay? If the patient is a little bit drowsy, and after a few hours he wake up and there is no symptomatic. Now, once they see that report, the thromboembolic team jump into the management, they will be contacted. You will let them start heparin therapeutic, or you keep it on prophylaxis? You just have a first surgery.
We put the patient on prophylactic. We stopped doing active treatment, curative treatment, because we didn't thought it would make a difference. And again, it was asymptomatic in all cases. So I don't think it's a big issue, but we still use prophylactic because we don't want the thrombosis to maybe extend. But I have the feeling because of the venous flow, because of the pressure, it cannot extend. In fact, the fear is always to extension to the vein of Labbé, for example. But I have the feeling that the flow is such that it do not extend, because there is this flow into the vein of Labbé and going into the transverse sinus to the opposite side that make the extension of the thrombosis difficult. It's a very interesting thing, in fact, those venous flow issues.
Ramesh, I have the feeling, Sebastian, that the non-dominant sinus may thrombose, that the dominant one doesn't.
I have exactly the same feeling. In a sinus who is really important, the risk of thrombosis is much lower. Another fact I found, and Takeo Goto is probably same opinion than me, because I learned this from his team. I stopped shaving the sinus with a diamond burr when we do combined, because it's burning the wall of the sinus, and it creates something on the wall and the endothelium of the sinus. So we use Ranger now to avoid, this diamond burr on the surface of this very fragile wall of the sinus. And I think this also can create thrombosis. I didn't compare drilling to Ranger yet in terms of percentage of thrombosis, but the wall of the sinus is extremely fragile, don't like coagulation, the wall don't like burning with the diamond drill.
Thank you, Sebastian. That is a good point. Giovanni, before we move on.
No, just to add something of what they say, Sebastian. He said one more important thing that I didn't mention in my presentation, and Vladimir too, is neo-navigation. With neo-navigation, you know if the sinus is dominant or not from the side of the lesion. And that is something that can prepare you to what will happen. And then, again, I completely agree. Rongeur is better than diamond drill. That is always eating something, and that is that. I mean, nervous tissue and vein are not like eating. Thank you.
Thank you very much.
Just a quick comment, sorry, just to make it
no
clear.
problem.
It doesn't mean we don't use the drill. Huh? We shave, but the last thin shell of bone, we take it out with a Ranger. We don't drill until the bone disappear and eventually the wall of the sinus is heated.
Yeah, understood. Tom?
I think we can't leave without making the point, because some listeners may come up with the wrong message. I don't think we I think we all agree that we want to preserve sigmoid and transverse sinus. Yeah. So we even the drilling, the non-hot drilling and so on, part of it is designed not to induce thrombosis, and thrombosis, although it may not immediately lead to a disaster, it can cause lots of problems even further down the line, including BIH type of symptoms, sometimes even CSF leak as a result of BIH and so on. So I think we all want to preserve the sinus, and also, people when they start operating, they'll worry about bleeding, and it's really the consequence of injury to a vessel is much worse than the actual bleeding. Yeah.
Yeah.
So the bleeding from the sinus, we don't want to happen, but it's more the consequence to the sinus after surgery is a problem. Bleeding from an artery in itself is not the problem. It's the potential ischemia after surgery that is the problem, and that's what we need to keep in mind.
Yeah. Thanks, Tom. Can I also ask Prof. Brogi and Vladimir to look at the question and answer session? There are a couple of questions, some of which is already answered by our discussion, but if you don't mind just answering it through that chat section, that'll be great. Imad, you want to go ahead?
I think we should move to Professor Abuzur to chair the second session.
Yes.
Are we okay?
Abuzur, can you unmute?
Yes, we will continue with some more challenging areas, petroclival area and the brain stem. Firstly, Sebastian Crowley will talk about the petroclival region. Please, Sebastian, you can share your screen.
Yes, can you see me? Yes, can you see my screen?
Yes.
Yes.
Yeah.
Perfect.
Okay. So first, thank you very much for the opportunity to speak. I know that there was many of us that wanted to speak, and I was fortunately chosen. So thank you very much for this opportunity. So petroclival is definitely a very difficult lesion to treat. We all know that. Starting with definition, because it's important to all agree of what we are talking about. For me, petroclival are really those lesions coming from the crossroad between clivus tentorium and petrous apex. 5 is displaced either laterally, inferiorly, or superiorly, but not medially. And it's very often going into Meckel's cave and sometimes into the posterior cameral sinus. I like very much this classification from Kawase, except that I don't really consider petrous apex type of petroclival meningioma as a true petroclival, because again, in some of those, 5 is pushed medially, and it's a completely different challenge. I like this classification based on feeders, because in skull-base surgery, for those centrally located meningioma, understanding of the feeders is also the base of the surgical strategies, because all those skull-base approach are dedicated to reach the tumor base first. And why we want to get the tumor base first is to control the feeders of those meningioma. So this is just a cartoon to show you the different types. This is petroclival type of petroclival with 5 pushed laterally, and the 6th is pushed medially. When the tumor base is a little bit more medial, it's a clival type. And in this case, sometimes 6 is pushed laterally, and sometimes it's inside the tumor. I had a case yesterday, in fact, and 6 was really inside the tumor. This is a tentorial type. It's much easier technically. 5 is pushed down, as well as 7 and 8. And this is, even if it's a large tumor, a good indication for a retrosic craniotomy. And this is an anterior petrous type with sometimes 5 pushed medially, but most often 5 is pushed superiorly against the tent. And it's a risk when we cut the tent to cut 5 also at the same time, because 5 can be very thin against the tent. Petroclival and cavernopetroclival are different type of tumors. In this category, the tumor arises from the arachnoidal granulation of the arachnoid sheath of the nerve inside the cavernous sinus. The nerves are not protected by arachnoids, so they can be infiltrated by the tumor, even in case of petroclival extension. So the relationship with the nerve are different, the challenge is different, the risk is different. Same with size and extension, completely different challenge between a small pure petroclival and a giant sphenocavernopetroclival tumor. It's completely different in terms of risk, in terms of surgical strategies. Even more risky is whenever there is brainstem edema. Whenever there is brainstem edema, the risk of injury is significant if you try to peel this tumor from the brainstem. It can be devastating. So I was talking about feeders. I will take a little time to discuss about feeders in petroclival. I absolutely love this paper from a French team describing the arteries of this petroclival region. I advise you to read it. It's beautiful dissection and really give you a great understanding of the feeders. This is arteries coming from the meningohypophyseal trunk. It's a dorsal marginal artery on middle clival. There is arteries here coming from ascending pharyngeal through the hypoglossal canal. And there is arteries coming from vertebral artery, sometimes anterior meningeal artery. All these can be connected together. This is drawings from one of my previous fellows, Kentaro Watanabe, showing this dorsal meningeal artery and medial clival artery, which are the main feeders of petroclival meningioma. When the epicenter is a little bit lower, quite often you have significant participation from ascending pharyngeal. This is hypoglossal branch. And all this is connected together, obviously. And you also have the tentorial marginal artery, which is also a very important feeders in those tentorial type of petroclival. So to me, we always do for large or giant petroclival a 3D angio to really understand the feeders. Some feeders are embolized from the ICA, from the ascending pharyngeal arteries. But then during the surgery, we choose the approach, we choose to focus on a part of the tumor base according to what we have seen on the 3D angio. Ascending pharyngeal feeders are difficult to control surgically, except the tiny branch of the internal auditory canals that you can reach with anterior petrosal or posterior petrosal approach. But the jugular foramen and the hypoglossal branch are difficult to reach, and it's a perfect indication for coil not particles, if you don't want to have cranial nerve injury, because some of those branches, they feeds also the lower cranial nerve. So treatment option for petroclival observation is definitely an option because those tumors are sometimes very slowly growing. Surgery, I am not fighting to take all the tumor out. I combine it quite often with radiation therapy, not necessarily upfront, but during the follow-up if it grows. Radiosurgery as a first option, yes, it's a great option for small petroclival. I have to say we use it very often. And in elderly patients with hydrocephalus, it's not a shame to use a shunt just to release symptoms due to hydrocephalus. I will not go into details for small tumors, but wait and see, I think, is a good option. Treating either with surgery, very low risk of radiosurgery is a good option, definitely when the symptoms come. I think we should not follow those tumors too long to miss the time where radiosurgery, for example, is not possible anymore. Radiosurgery works well, and we have a lot of evidence now that shows that for those small tumors, it works quite well. 8 cc as a threshold has been described as a valuable threshold to decide between surgery and radiosurgery. About the surgical approach, we have retrosig, posterior petrosal, anterior petrosal. We have those transtentorial transmecal cave approach, and we have the combination of some approach, which is a combined petrosectomy. Retrosig is great to me, definitely, but it's only one entry point, and you have to work between the cranial nerve, and you don't have necessarily the same control of the feeders. So it may bleed significantly during the operation before you get the good control of the feeders, which may be an issue whenever you have to work between the cranial nerve. A paradox with the retrosig, in fact, is I prefer the retrosig for larger tumors and for small ones, because when the tumor grows, it creates more space between the cranial nerve, and especially for the tentorial type, which push the lower cranial nerve, the 5 and 7 down, and sometimes create a very nice corridor above the nerve to work. But it could be the case also for petroclival. So it's an important factor for me. It's to look on the cis sequences, 3DT to locate the nerve and to see the corridor you can get with a retrosig between the cranial nerve. And whenever this corridor is large, I think retrosig is a great option, whatever is the size of the tumor. We had this publication from Marcos Tatajiba, extremely honest publication looking at this result with retrosig. And you see that the number of cranial nerve 7 facial nerve palsy is significant. It was 34%. Most of those patients, vast majority recovered, but still 34% is a significant number. And I think it's exactly due to the fact that we work between the cranial nerve during the entire operation. So I have to say, I don't use this pretemporal transcavernous approach. I use it only for sphenocavernopetroclival tumor, but not for pure petroclival tumors. I don't think it makes sense to cross the cranial nerve to get in the posterior fossa through the tentorium, through Meckel's cave, to get to the main part of the tumor. But in case of a cavernopetroclival, when the epicenter of the tumor is a cavernous sinus, yes, definitely it's an option. This is a variation of it, the same. So transpetrosal approach, I think it's a very nice option in large or giant petroclival because it's really an approach that exposes the tumor base of the tumor. The petrous bone is really an arrow that you can follow to the tumor base of the tumor to devascularize, to get into the tumor for debulking before working around the tumor. Transpetrosal approach is made to target the feeders, to get to the feeders coming from middle meningeal artery. Obviously, when you do an anterior petrosal, you cut middle meningeal and the ICA branches from meningohypophyseal trunk. We do for those approach a very careful preoperative workup. It's a complex approach, but all the issues you can have during the surgery, we were discussing about sinus injury, vein of Labbé, the veins that drain into the sigmoid sinus, diploic veins, all those issues, you can have an answer before the surgery, looking very carefully to the preoperative workup, CT scan, bone CT scan, thin cut, MRI with C sequences or Fiesta sequences to look at the cranial nerve, and 3D angio. This is some example of CT scan where we look at the depth of the cochlea, the pneumatization of the petrous bone, the height of the high jugular bulb. We have a lot of criteria that we look at before jumping into a transpetrosal approach. 3D angio, as I said, is extremely important to understand the feeders, to look at the venous drainage, and to embolize the tumor. I have to say that in the vast majority of large or giant petroclival, we do some embolization. Embolization is great because it definitely reduces the risk of significant bleeding during surgery. Sometimes when embolization have been significant, you get to the tumor and it's almost necrosed with almost zero bleeding. It can happen. So it clearly reduces the resection time. And the tumor may be much softer also because of this necrosis of the tumor. We do 3D angio the day before, and I had few occasions when I staged the surgery. I did the 3D angio and embolization before the first stage. At the time of the second stage, 8 days after, the tumor became fibrous, and definitely it was also due to the scar process. So don't wait too long between embolization and tumor resection. Venous consideration is extremely important, looking at the dominance of the sigmoid sinus, looking at the transverse sinus, not connected sometimes to the torcular vein of Labbé, superficial middle cerebral vein, deep middle cerebral vein, petrosal vein complex, hemispheric anastomosis. This is extremely important because a significant number of complications in transpetrosal approach are related to venous issues. I am more afraid about venous issues than arterial issues in those tumors, except if there is brainstem edema. So I will go fast on those publications that describes the suprapetroral sinus. Sometimes you have to be aware that there is no connection between middle suprapetrosal vein and the cavernous sinus. And in fact, this number increases when you have a petroclival meningioma. Quite often, there is no connection because the tumor has already occluded this medial part of the suprapetroral sinus. And sometimes also it has occluded the petrosal vein. But it's important to know that before the surgery, because if you can preserve, you have, and to preserve, you have to cut the suprapetroral sinus as medial as possible. This is also a publication looking at the middle cerebral vein, superficial and deep. And between black and red, you see the differences in drainage pattern between case control and petroclival meningioma. Petroclival meningioma change the drainage pattern.
I think we lost Sebastian there.
Sebastian?
Maybe network issues. Should we wait for a minute?
I will give him a call.
Yeah, maybe it's just a network issue.
The pity. This must be connections since the slides are not moving. You would move them.
Yeah, and also Sebastian's picture is frozen, so it's definitely a network issue.
Right. Hopefully he will come back.
Yeah, I think he's logged out. So
he's coming back. Yeah.
I think it is better to continue with Takaragoto.
Well, did you get in touch with Sebastian Imado?
Yeah, I'm trying.
He's back. He's back. You can unmute Sebastian. Can you unmute?
Sorry. Yes, I was keeping talking alone.
No. I think you didn't. We didn't miss much.
Hopefully you called me because this could last for an hour.
No. Don't worry. Don't worry, Sebastian. We are following the facial expression of the.
So So anterior petrosal, I use it for large tumor, mostly petroclival upper clivus type when there is Meckel's cave extension, because anterior petrosal is an access to Meckel's cave. Whenever there is middle fossa extension along the lateral wall of the cavernous sinus in the lower aspect, it's a great indication for this. Whenever the tumor is going very low, then it's an issue because you cannot reach that. It's an extradural approach, as you can see here. Great approach to control the feeders I told you about coming from meningohypophyseal trunk, because you have a direct access to this network of arteries when you have exposed the posterior fossa dura. Drilling zone, there is different area of drilling option depending on the exact epicenter of the tumor. It's very well described now, the technique of drilling. I have a specific path of progression during the drilling. It's important to understand that anterior petrosal is a looking down approach. It's not a looking up approach, because if you want to look up with an anterior petrosal, it means that you need to retract the temporal lobe more. And this is exactly what we want to avoid. So the anterior petrosal is made to reach the lower aspect, the lower part of petroclival meningioma. For this, you need to drill more laterally. The more you drill laterally, the more you can look down to the tumor. We have looked at our result with anterior petrosal and find out that the morbidity, if you have the proper technique and some training, is in fact quite limited. We had few cases of temporal lobe injury, and this is why we are extremely careful now with retraction. I use dynamic retraction with stitches. I am not using blade anymore. I like to see the brain pulsating while I am doing the drilling. This is a case where I used anterior petrosal. This tumor was progressively growing, and it's not a big tumor. For me, it was a good indication to use anterior petrosal. I go fast on the surgery just to show you the end of it, that we use at the end to control the area of Dorello's canal. We use the endoscope because I want to keep Dorello's canal on 6th nerve. So I left a little piece of tumor around Dorello's canal in this patient who was a woman with a progestin-related meningioma, so extremely low grade. It's a very good case to follow after surgery, this remnant. And in case it grow, you use radiosurgery. This is here the postoperative MRI showing this little remnant around Dorello's canal and also a remnant in the lower clivus. Combined petrosal, I use it mainly for larger tumor, giant tumors. I like this multiple line of sight that it offers. You can look at the tumor from multiple directions. On each part of the tumor, each critical relationship with vessel or cranial nerve has an optimal line of sight to work on it. And this is, to me, the beauty of this tumor, in addition to have a fantastic control to the tumor base. So I use it for large and giant petroclival clivus type whenever 5 and 7 are displaced laterally. Posterior petrosal is a looking up approach. It's exactly the opposite of anterior petrosal. We use the corridor of the mastoid process to work behind the labyrinth, to look up below the temporal lobe. And you understand with this cartoon that to be able to do that, you have to transpose the junction between sigmoid sinus and transverse sinus posteriorly a little bit. And this allows you to work below the temporal lobe without a need, in fact, for temporal lobe retraction. Very similar concept to the FTOZ concept, temporo-occipital approach, combined petrosal approach. You drill the sphenoid ridge on one case, you drill the petrous ridge on the other case, you finish with anterior clinoidectomy if needed, you finish with anterior petrosectomy if needed. The petrous apex is the tip of the petrous ridge, the clinoid is the tip of the sphenoid ridge. You work between temporal lobe and cerebellum, you work between frontal lobe and temporal lobe. Tentorial artery devascularization is extremely important in combined petrosal. And the key step of this operation is the resection of the tent, because the tent is a tumor base, or most of it. You cut the tent with an anterior cut, posterior cut. You open a window on the petroclival tumor, and you transform the tumor in a convexity tumor. So tentorial resection is absolutely a key step. If you do combined petrosal, but you don't resect the tent, you lose the value of the combined petrosal approach. Whenever there is hearing loss before the surgery or very low hearing, non-useful hearing, you can easily drill the labyrinth to gain more exposure. I will show you a case. This is a technique I used before with this big C-shape incision. I have changed the technique. I am using now a kind of mini combine. I know you don't like to hear about mini, but still mini means that we try to reduce the footprint of those operations. And the footprint related to the approach is significant. A significant number of our patients don't complain of the beautiful work we have done intradurally, especially if it's successful, but they complain of issues, temporalis muscle atrophy, TMG disorder, sensory issue of the scalp. So the lower we can be aggressive with the soft tissue, the best it is. I will quote Takeo Goto publication about this, because he is the source of our inspiration for this reduction of the footprint. This is what we do. We published on it. We use now this purple incision. Here is a dissection of it where we try really to reduce the mobilization of the soft tissue, and we focus really the operation on the petrous ridge. We don't do posterior petrosal and then anterior petrosal. It's a combination of both. That's why it's a combined petrosal approach. And the combination of both is to focus the work on the petrous ridge. So we only drill what is needed to be drilled to get to the target. This is here a case of a petroclival that I used where I used this technique. And this is here a drawing showing that we are not exposing the facial nerve. We are not exposing the lateral canal. We are just exposing superior canal and posterior canal. And this is here a small video. So really, really careful soft tissue manipulation, because again, this is also source of morbidity. We do a cosmetic mastoidectomy. You see here that I use the ronger to take the bone out. I start here in this case with the anterior petrosal approach, but sometimes it's reverse. It depends on exactly where is the target and on how it works. Extremely important, and I didn't show it, we drain about 50 to 60 cc's before opening the dura, before doing the petrous bone drilling, after the craniotomy. Like this, everything shrink, and it's like naturally, the dura is going away from the bone. So then you can peel the dura from temporal fossa floor, peel the dura from the petrous bone, expose the petrous ridge like you would do it in an FTOZ approach with the sphenoid ridge. At the end of the operation here, after taking the vast majority of the tumor out, I put the endoscope because there was some tumor above the sella turcica compressing the optic nerve. It was a radiation-induced meningioma in this patient that has been treated by radiosurgery, and it was a recurrent case. So quite difficult indication, but hopefully the tumor was very soft, and I was able to resect the tumor not with so much difficulties because of the consistency of the tumor. This is a post-operative MRI showing that there was a remnant suprasellar, but not much. And I had to go back very recently to take this remnant and the suprasellar part that was growing. I will skip this and finish with this conclusion that consistency, vessel encasement, brainstem infiltration, cavernous sinus infiltration dictate the amount of resection. It's not the surgeon who decide what the amount of tumor will be taken out. It's a characteristic of the tumor, and I think it's very important to have this in mind. It's not a fight against the tumor, it's a fight to preserve the patient. So transpetrosal is great for large tumor. Functional preservation is my priority. We still have morbidity, definitely, but the goal is to keep the patient intact. I am extremely careful in case of brainstem edema or vessel encasement, and we try to reduce the footprint of our operation, and this is coming with experience. Thank you very much for listening to me. Thank you.
Thank you.
Thank you for your excellent presentation. The discussion will be at the end of the session, and the next presentation will be from the Takeo endoscopic keyhole approach to petrous apex. Please, Takeo.
Okay. Okay, there.
Yes, yes.
Can you hear me? Okay.
Yes, we can hear everything is okay.
Okay, so today my talk is endoscopic keyhole anterior transpetrosal approach to the tumor around the petrous apex. Our institute, Osaka Metropolitan University, is one of the largest skull-based center in Japan. So our old mentor, Professor Hakuba, started a combined transpetrosal approach to petroclival meningioma. And also my mentor, Ohata, and also I use a combined transpetrosal approach to large petroclival meningioma. But recently, to small or medium-sized tumor around petrous apex, I usually use the endoscopic keyhole anterior transpetrosal approach. Today, I will show the anatomy of the approach and also surgical tips. This is an illustration of the microscopic anterior transpetrosal approach. The key point of the anterior transpetrosal approach is opening of the Meckel cave and expose the trigeminal nerve from Meckel cave to brainstem. This is a surgical tip of the microscopic anterior transpetrosal approach. But recently, this surgical view can be get through the endoscopic keyhole approach. At first, I will show the anatomy of the keyhole anterior transpetrosal approach. Usually, I put the skin incision around temporal base and then put the craniotomy with the size of around 3 centimeters. And then after the CSF drainage from the lumbar drain, I slightly retract the temporal base and insert the endoscope to temporal base. We can see the trigeminal nerve covers the dura mater, and also if we use a facial nerve stimulator, we can identify the cause of GSPN. After identify the cause of GSPN, I cut the dura mater, medial side of GSPN. This view, this is a temporal base, and this is a petrous bone, and this is a trigeminal impression, and GSPN. So this bone, bony part is Kawashi's triangle. I drill out this part through the endoscopic view, and then open the Meckel cave. After that, we can expose the trigeminal nerve from the Meckel cave to brainstem. So this is our endoscopic keyhole anterior transpectrosal approach. We can observe the entire course of trigeminal nerve from Meckel cave to brainstem, and also identify the SCA, fourth nerve, or sixth nerve. So this surgical view is very similar with that of microscopic anterior transpectrosal approach. I will show the several cases. This is a medium size of the trigeminal schwannoma showing the numbness of hemiface. So I use the keyfold anterior transpectrosal approach and my endoscope. This is our surgical video. At first, I put the craniotomy with a size of 3 centimeters, small craniotomy, and then we insert the endoscope through the subdural space. And then I stimulate the dura mater to identify the cause of GSPN. After identify the cause of GSPN, I cut the dura. This is a trigeminal impression, so I limitedly expose the petrous ridge around Kawase's triangle. And then I carefully drill out just petrous apex to expose the dura mater of the posterior fossa. And then I ligate the SPS, just lateral side of Meckel cave. Now I open the Meckel cave, and this is a tumor. In case of the trigeminal schwannoma, after expose the tumor tissue, just continue the subcapsular dissection. This is a tumor in the Meckel cave. We can get the very clear view in the Meckel cave, and we can dissect the tumor from the normal trigeminal fiber. We repeated the tumor resection, and finally all tumor was subcapsularly dissected out. This is a temporal lobe, and this is a temporal base. This is a Meckel cave, and this is a posterior fossa. Now all tumor in the Meckel cave was resected out. This is a post-op MRI. Through this keyhole, all tumor was nicely resected out. This is another case of the also the trigeminal schwannoma. I use the same procedure. Always incision is the same, and I put the craniotomy with a size of 3 centimeters, and then insert the endoscope. This is a dura mater over the trigeminal nerve. I carefully dissect the dura mater and then expose the tumor. Now I go into the tumor. This is a normal trigeminal fiber. After expose the tumor, I continually perform the subcapsular dissection. Endoscope can offer very good view. This is a Meckel cave, and this is a carotid artery in the Meckel cave. I coagulate and cut the SPS to go to the posterior fossa, and then continue the subcapsular dissection. This is a normal fiber of the trigeminal nerve. I carefully dissect. And finally, we completely resect the tumor from the posterior fossa. Like this. So this is a brainstem and a pons, and this is a normal trigeminal nerve. Postoperatively, all tumor was nicely resected out through the keyhole. This is another case of the trigeminal schwannoma. This tumor occupies a Meckel cave and a posterior fossa and infratemporal fossa. But also endoscope can offer good view around Meckel cave, posterior fossa, and infratemporal fossa. So I use the same procedure, a small incision and insert the endoscope, same procedure, and then expose the Kawase's triangle, and then drill out the just petrous apex to expose the dura mater around posterior fossa, and then open the Meckel cave and continue the subcapsular dissection. Endoscope can offer good, clear and magnified view, so we can perform the very gentle subcapsular dissection. And this is the tumor in the infratemporal fossa. I additionally drill out the bone to resect the tumor in the infratemporal fossa. Endoscope can offer a good view, so I repeat the subcapsular dissection and confirm the whole tumor was resected out, like this. Postoperatively, the tumor in the Meckel cave posterior fossa and also infratemporal fossa tumor was resected out. In some cases, a tumor just occupies the posterior fossa. This is a trigeminal schwannoma, but this tumor also can be safely resected through the subtemporal anterior transpetrosal approach. I use the same procedure. I skipped some surgical video, but anyway, to open the Meckel cave and go into the posterior fossa, I dissect the subcapsular dissection, and finally, all tumor was resected. The brainstem and posterior fossa. Skin incision is small, and also tumor was nicely resected through the subtemporal anterior transpetrosal approach. If the tumor relatively large, our surgical procedure same. This procedure is especially very effective to resect the trigeminal schwannoma. This is the dura mater over the trigeminal nerve. I carefully cut the dura and expose the trigeminal fiber and petrous apex. This is a normal trigeminal fiber, and this is a tumor. I carefully perform the subcapsular dissection like this. And then this is a petrous apex. I drill out the petrous apex to expose the dura mater around posterior fossa. And then I continue the same procedure. And normal trigeminal fiber preserved, and tumor was resected out. This is a tumor in the Meckel cave, but endoscope can offer the good view between the tumor and the normal fiber. And finally, all tumor in the Meckel cave was resected out. And this is a post-op MRI. Tumor was nicely resected out, even the size of tumor large, in case of the trigeminal schwannoma. This approach also can be applied to the petrous apex small meningioma or medium size of meningioma. This patient shows uncontrollable trigeminal neuralgia after gamma knife. So I choose a less invasive procedure to relieve the trigeminal neuralgia. The size of craniotomy is the same. And then I insert the endoscope to subdural area, and I stimulate and identify the GSPN and cut the dura medial side of GSPN. This is a petrous apex, and this is a Kawase's triangle. I carefully drill out the petrous apex. This case, attachment of the tumor is anterior petrous ridge, so already tumor was devascularized and detached, so we can perform the very safe resection. I cut the tentorium more medial side to identify the host nerve, like this. And then I carefully dissect the tumor from the tentorium and resect the tumor totally, like this. This case, tumor compressor SCA and SCA compressor trigeminal nerve. So I carefully mobilize the SCA of the trigeminal nerve like this. So trigeminal nerve was completely relieved. When we insert the endoscope more deep side, we can see 6th nerve and 7th and 8th nerve. So this surgical view is very similar of the anterior transpetrosal approach. So petrous apex was limitedly drilled out and the tumor was nicely resected out. This is a recurrent chondrosarcoma associated with osteogenesis imperfect. For her vaginal invagination, this angle was very steep. So it's very difficult to reach the upper margin of the tumor, but endoscope can see the upper margin of the tumor. This is the fourth nerve, and this is the tumor. This case also the size of craniotomy is small, but we can reach the posterior, superior edge of the tumor. We carefully dissect the tumor from the trigeminal nerve, and this is a brainstem. We can very clear view around the petrous apex and the brainstem. So all tumor was nicely resected. This is a trigeminal nerve. So tumor was resected out like this. This is another case of the small size of the petroclival meningioma. But during the follow-up period, the size of tumor increased very quickly, even her old age. But so we choose less invasive treatment to resect this tumor. I use the same procedure. The size of craniotomy is the same, and procedure also same. We gently expose the dramata over the superior surface of the petrous bone and identify the cause of GSPA, and then cut the dura, medial side of the GSPA. And this is a trigeminal V3 nerve, and this is a trigeminal impression. So this part is a Kawase triangle. I carefully open the Meckel cave like this, and then drill out the anterior petrous bone. And this is a tentorium. I carefully cut the tentorium and then start the internal decompression. This is the attachment of the tumor, medial side of trigeminal nerve. I carefully detach the tumor from the attachment of the tumor. Some part was calcified, but I resect the tumor piece by piece. Endoscope can offer very clear view. And finally, we reach the tentorial edge and resect the tumor. This is an oculomotor nerve. I resect the tumor around the third nerve and confirm the brainstem was completely decompressed like this. So this is a post-op MRI. Tumor was nicely resected out with the preservation of the facial, hearing, another neurological function. This also the petrous apex meningioma, but also this approach can be applied and tumor was resected out. This is another case of the small cavernous and petrous meningioma, but endoscope can offer the good view around this area. And then most part of the tumor was successfully resected out like this. So today I will show the mainly surgical video of endoscopic keyhole anterior transpetrosal approach. This endoscope endoscopic view gives a good view around petrous apex. And one of the benefits of this approach, we insert the endoscope to the subdural space, but fortunately, in our surgical experience, there is no large cortical vein around the anterior part of the temporal base. So we can safely insert the endoscope and observe the petrous apex and brainstem. One of the very important safe point of the endoscopic approach is that if we can keep the very safe area just behind the camera, we can safely resect the tumor. This is a good point of this approach. We published this technique to JNS this year. So if someone interested this approach, you can check this paper soon. Thank you for attention.
Thank you, Takeo, for your extraordinary presentation. We will continue with the transventricular approach to brainstem awareness malformation. Professor Miguel will give the lecture. Please, Professor.
Thank you very
Yes.
much. First of all, I'd like to thank the leadership of the IANA for the kind invitation to take part of this wonderful webinar. I also like to congratulate my very good friend Pablo González for his appointment as chairman. And I also like to congratulate all the speakers. I have very much enjoyed all the presentation. My topic will be in regard to transventricular approaches to brainstem cavernoma. And we have to mention something about the indication for cavernoma surgery at the brainstem. We will also mention something in regard to the appropriate timing. Next point is how to get inside the foreventricle and main indication, pontine tumors, medullary tumors, and also cerebellar peduncle lesions. And the last aspect will be which alternative routes to the foreventricle can we find in regard to the surgical management. Just only one slide in regard to surgery versus conservative treatment. This is a 20 years old patient with 2 episodes of transient right facial palsy. I think we all are aware of the natural history of cavernoma lesion at the brainstem and posterior fossa. But in a patient that is neurologically intact, the decision is not always easy. And I think this is one of the examples. Next step is how to get the fourth ventricle. We can go through intertonsillar approach, basically for medullary tumor, lower medullary tumor. We also have the possibility of the classical transvermian approach. And also Professor Benes mentioned something about the telovelar approach in regard to the route through the foramen of Magendie, tela colloidea, and inferior medullary velum. And we have these possibilities to get inside. And talking about cerebellomedullary fissure, we have to mention, of course, Professor Matsushima. I had the chance to meet him last time in Istanbul, and I think he has many relevant papers in regard to all the details about how to get not only the foreventricle, but also the cerebellar peduncle area. And this is one of the examples. If we are dealing with lower medullary region tumor, this is a patient, 18 years old, sudden tetraplegia, respiratory arrest. The patient came round, and this is the black spot in the ultra acute MRI examination. But for this lower medullary region, we have to do a simple tonsillar intertonsillar approach and remove the lesion in the same way as we do with intramedullary tumor. And this is the way, just going through the posterior intermediate circuit that we can get inside, and we can find the clean plane between the normal tissue and the cavernoma. This is the postoperative intraoperative view, very nice, and this is the satisfactory postoperative MRI. This is another case, a 4-year-old patient with tetraplegia and respiratory arrest. You have to do this operation in emergency basis sometimes, and you can see the lesion at the, in this case, the upper medullary region, and the way of removing that. You can see bottom, you can see this clean plane after removal of the tumor, satisfactory MRI. This is a lesion, particular lesion, because it was two tumors in collision, one brainstem cavernoma and benign low-grade pilocytic astrocytoma. And this is the postoperative MRI after a complex operation due to this mixed nature. And well, talking about the region of the Pontine area, we have to keep in mind, of course, the so-called safe entry zone, median sulcus, and also the supra and infrafacial triangle, in order to preserve the 7th and 6th nerves. We have to do that by means of a simple occipital craniotomy, and this is a patient with progressive diplopia and growing lesion. In this case, this is one case done many years ago, and at that time I used to go through the Birmingham region, not using the transcerebellomedullary fissure. But in this case, the surgical approach is very straightforward. You had the lesion occupying the whole floor of the foreventricle, of course, the bulking of the lesion, and then working in the plane that is the key for the success in this operation, the management of the plane between the tumor and the normal tissue. In Racemose tumor, we have to be very much aware, because sometimes you can have the impression you have removed everything and you can have some remaining tumor. You can see here in this case some big part of the tumor embedded inside. And if we do leave some part of the tumor, we are not reaching our goal, that is diminished to zero, the possibility of bleeding or rebleeding. You can see the area. This is the tumoral bed. This white V is the normal for ventricle. And this is the postoperative MRI, pretty satisfactory. The patient is an artist, and this is the picture painted that is in my office, and this is his conception about the cavernoma we have removed. But we have to be sure that the tumor is not recurring, because we know that in certain proportion of cases, even having the impression that postoperative MRI is fine, and also the intraoperative impression, sometimes we do have the recurrency. This is the tumor recurring 14 years after the initial operation, and this is the new operation regarding the removal, trying to find, as always, a clean plane. Well, with the technique you all know very well, and this is fortunately after the removal, in some areas difficult because of some gliotic plane that may give some postoperative problems. This is another patient, 20 years old, hemiparesis, left 6 nerve palsy, second episode of bleeding, and in cases like that, I think it's important the concept of foreventricle mapping, as you can see here. helping to get inside the brainstem and helping to preserve 7 and 8. And this is bottom right, you have the postoperative view with this clean plane that gives you a very good impression in regard to the postoperative result. Of course, needless to say that all these cases need a very, let's say, extremely fine intraoperative neurophysiological monitoring. And this is the MRI at the left, and this is the patient with some diplopia. The patient had some increase of the hemiparesis, that is something normal after this kind of operation, but these are very satisfactory operation because little by little, and mostly in young patient, the recovery is pretty satisfactory. This is another patient with 2 episodes of hemiparesis and facial deficit, and this is the postoperative MRI, but postoperative situation of the patient was not very satisfactory because there was a gliotic plane around, just making the operation difficult. And this is the patient with some slight hemiparesis, facial palsy, and some problem of the conjugate gaze. This is another patient, 22 years old, facial palsy, diplopia, first episode. This is an easy case, and I think more and more we have been moving to do in certain patients with, let's say, easy lesion, young age. We are very much prone to do the operation after the first episode of bleeding. This is the postoperative MRI. You can see that fortunately, this removal is not provoking morbidity. Also, we have to do surgery in acute stage in some cases. This is a patient we have to do in emergency basis due to this acute bleeding, a young patient, of course. This operation was a nightmare. We went through the fourth ventricle, but this cavernoma was bleeding like a real AVM. We managed to control the hemorrhage, remove the lesion, but if you see the postoperative MRI, you can see here some small areas just reported as persistent cavernoma. The patient is under follow-up without any further bleeding, but acute stage is deemed to be not the appropriate timing for the operation. Another aspect is the possibility of cerebellar peduncles. This is again a young patient with the second episode of bleeding, dizziness, ataxia, nystagmus, and this is the way you can get inside through the fourth ventricle. We do the mapping. I will move forward, and the way of just evacuating the hematoma and then evacuating the cavernoma. This is the immediate postoperative clip of the patient with almost no other neurological deficit, pretty good situation, and you can see the postoperative MRI with the image of the entrance inside the cerebellar peduncles. Well, we have seen in this case an approach through the third ventricle, fourth ventricle. Do we have to consider another possibilities? Well, we have to mention that we do have to consider different routes from the fourth ventricle because fourth ventricle has a very high potential morbidity. There are several other possibilities for cerebellar peduncles, retrosigmoid approach, transcerebellomedullaris approach, and the fourth ventricle that was the approach used in this case maybe more than 10 years ago. This is another example, pontomedullary cavernous medullary cavernous angioma. We have seen the cavernous angioma in close vicinity to the fourth ventricle, but if we look at the MRI, this particular area, that is the pontomedullary junction, can be very easily approached through a simple retrosigmoid route. This is 7 and 8. This is 9, this is 10, and in between 9 and 10, you can make the exposure of the lesion and the removal. This is after removal. We cannot see a very clean plane underneath, reason why the patient had some postoperative hemiparesis, sixth nerve palsy, and dysphagia. So it was due to the long time at the waiting list of the patient and some recurrences of the bleeding. And in summary, we gathered that the timing for surgery after bleeding, acute stage, is not the right moment, not either delayed surgery. And we gathered that subacute stage, maybe around 6 weeks or even less after the bleeding, would be the appropriate timing for the removal. And talking alternative routes, this is a patient with another cavernoma. You can see how the lesion is abutting the lateral recess of the fourth ventricle. In that case, we avoid the fourth ventricle. It was one of our initial cases years ago. We did a presigmoid approach. You can see the reflection of the temporal and cerebellar area, just cutting tentorium, exposing directly the fifth nerve, then the vein complex, and the way you can get inside in a very straightforward way, making some small opening and then elongating this opening, exposing the cavernoma and removing it. This is the postoperative MRI. I have to mention that now we are not doing anymore that approach because we understand that a very simple retrosigmoid approach is good enough to remove, irrespective of the size, to remove cavernous angioma at the lateral aspect of the pontine region. So in summary, talking about transventricular approaches to brainstem cavernoma, main indication are, of course, pontine and medullary cavernous angioma. We have to take into account the telovelar approach for pontine region, medullary region. Medullary area can be approached, the lower medullary tumor, through simple intertonsillar approach. Once we see the cavernoma in the vicinity of the floor of the fourth ventricle, we can do this route in certain cases, but if you have the possibility to go through any alternative route, is less dangerous for the patient. And finally, more and more insisting on the concept of safe entry zone. Thank you very much for your attention, and thank you very much for the kind invitation to participate.
Thank you very much for your presentation,
Thank you.
Professor.
I think we can start having some discussion, Dr. Abuzir. Yeah, we'll start with the
Yes.
first paper of Sebastian. Any comment or Vladimir?
Yeah, Sebastian, this is excellent. I don't see you. I see you now. This is excellent, and your results are perfect. You were saying one thing which you probably have forgotten, that quite a lot of these patients are women of 50, 55, being treated by their doctors by hormonal treatment. And if you take this away, they may improve and you do not need to do any surgery. But that's not what I wanted to say. All these tumors I approach with supra-infracerebral route. It means 20 minutes craniotomy, you are immediately there. The advantage is that as soon as you cut the tentorium, which is the second step of surgery, you very early on realize what the interface between the brainstem and the tumor is, and whether you should go for partial or radical. Another advantage is that you really move very low. You can get even lower than the 7th, 8th. You can get nearly as low as 9th, 11th. And the tumor helps you by itself to come out. The disadvantage, of course, is the fourth nerve, which is running exactly on the dorsal aspect of the tumor, and it's very, very tiny nerve which is difficult to preserve, but fortunately the lesion is the palsy is not that much apparent. Another nice thing about it is that you can very actively seek the sixth nerve, palsy of which is very terrible for the patient. So you really can very actively find it, and you can go along it. Disadvantage, on the other hand, is Meckel's cave. You can enter it, but you are coming very horizontal. So you cannot manage quite well, even if you drill off the apex, which is and the tubercle. It's not that difficult. But most importantly, I still think that this is an easy, very straightforward approach compared to any petrosectomy. How long does the petrosectomy takes you?
Good question. It's I have to say now I'm getting better with the approach. So I would say between 2 and 3 hours. But yes, it's a much longer operation. I use your technique. I use it for tentorial type of petroclival, and you're absolutely right. It's a great approach for this. I include it into my retrosig because instead of going in front of the cerebellum, you go above the cerebellum. That's the difference, and you cut the tent. So it's more an approach below the end of the transverse sinus than behind the sigmoid sinus. But I definitely use it, and it's a great option for the tentorial type because 5 is pushed down, 7 is pushed down. You have a fantastic corridor.
You do. Why don't you include it into your? Why don't you include it on the slide? At your lecture on the slide of the approaches, this one was not mentioned.
You need to send me a picture of your approach with your name, and I will include it. Definitely.
I will. With pleasure.
But it's great. But I consider it as a variation of the retrosig. It's a retrosig supracerebellar approach. It's like the extreme lateral infratentorial approach that you can also use to go to the lateral aspect of the mesencephalon for cavernoma.
Exactly.
So
it's very versatile. And whatever is above the meatus, you can approach it with supra-infra very easily. Pontine cavernomas, the thing Miguel was showing. Some of them I would approach by this approach, those upper pontine cavernomas. And for
completely agree.
Meningiomas, it's the best I ever had.
We have a publication together on this matter. Lorenzo Giammattei did a publication, and I have a case in this paper.
Yeah, we should do that. Good.
So we agree, but we have the publication. It's published.
It is. It is published in ACTA, and now about supra-infra, it will be published in a book we did with IMAT.
And you still
there will be a whole series.
Yeah.
Yeah.
So it's in my mind. It's in my practice.
Good.
Keki, you have.
Yeah, in fact, yes. One of the first petroclival meningiomas that I did was by this very approach in 1989 by the lateral supracerebellar. And I had the patient was brought in a tetraplegic condition with multiple cranial nerve palsies. And by Jove, I could get the complete tumor removal and a dramatic recovery. And later on, when I presented this case, when I was visiting Osaka, and Professor Hakuba had invited me to his university, and Ohata was there. At that time, Hakuba said, it's a great approach, but this is because your meningioma was soft. That is why you have such a good approach and such a good result. So my question is, does this not matter, the consistency of the tumor? One is approach, your ability to see the critical neurovascular structures by whatever approach. That is the aim of any approach, is to get to the critical neurovascular structures and to get to the arteries which are supplying the tumor at the earliest. If you can satisfy all these criteria, but a very important player in the game is the consistency of the tumor, apart from vascularity. And any approach will look very difficult if the tumor is fibrous, and it look very easy if the tumor is soft.
Of course.
Yeah.
One of the advantages of your approach, Sebastian, probably would be that you get earlier on to the blood supply.
The tentorial artery.
Yeah, the tentorial arteries.
I think it's the reason why we have multiple options is to adjust the option to the feature of the tumor. The more information you get on the tumor about epicenter, feeders, consistency, the more you can adjust the technique to those characteristics. There is no approach would do the job great for every patient.
Yeah, the more information you get,
perfect illustration.
Sebastian, the more information you get, the more you go for observation.
It depends. I have seen every scenario. We have published extensively on this relationship between meningioma and hormonal treatments, and you're right about the fact that it can shrink, but it's very rare for petroclival tumors because the genomic landscape of petroclival is slightly different. And it's usually not those tumors that shrink after you stop the medication. In fact, I never saw it for a true petroclival. I saw it for Petrosapex type, but not for petroclival.
Sebastian, I'd like to commend you on that presentation because I was privileged to review your paper when it was submitted for publication. And I feel you have moved ahead from a very complex approach. This is a different time of Professor Hakuba for the combined approach to the time you have tailored it and make it less invasive. Let's use different wording, not minimal invasive, but less invasive. But I think the other things, the simple, what they call it, the plastic mastectomy, we should give the credit for Taka Fukushima. This is the first time I learned about it, where he taught me with the oscillating saw to cut the triangle of the cortical bone of the mastoid and start doing and replating this back in the position for pre-sigmoid. Now, very interesting if we want to discuss your paper with Takio as well, because this is a progression. In one institution, it shows how much if people focus and give a good teaching to their group, they progress from complex to slowly less complex. Hakuba approach was a combination of 3 approaches, including fronto-orbital zygomatic to catch up of the posterior cavernous sinus as well in the procedure, moved to Ohata, and we saw Takio tackling the smaller tumor and the medium-sized tumor nicely with the endoscope. How your take on this? I know you referred many of the credit to him by some of the technology you adapted in yours. And I like your quotation, what you said is an analogy, the rional approach and the petrosal approach is exactly a mirror image of the concept. So how do you see the points of Takio going into endoscopy? Because I want to know, I saw that it's a dynamic endoscopy. It's not a fixed endoscope. And because people put the endoscope on the stand or on a snake or whatever, it loses the value of the depth and the dynamic and how he is handling in that position, having more hands to help because he's using 2 hands. So somebody is holding the scope, the co-driver, most probably he should be much trained as the surgeon himself.
Well, if the question is for me first, Takeo, is to say that definitely Osaka team is a source of inspiration for us. And for the mini combine, definitely looking at their work was important to us. Hakuba, Ohata, and now Takeo is, I mean, it's a fantastic team, always coming with new things. I have not used yet this keyhole endoscopic approach. I think it's great. I think the indication need to be probably refined according to experience. You showed several cases of trigeminal schwannoma. I have to say that trigeminal schwannoma for me is an issue, and I have not found yet a solution. And the main issue for trigeminal schwannoma for me is the trigeminal nerve and the trigeminal nerve function. And my results have not been great, whatever the approach I have been using in terms of trigeminal nerve function. Hypoesthesia is really an issue for patient. It's not something you can see on the face of the patient, but it's something the patient feel 24 hours a day. And I think we have for this trigeminal schwannoma really to find a way to treat those tumors, which are usually not very aggressive, with function, to keep the function. Transorbital, keyhole, retrosig. I don't know, endoscopic, endonasal. I have used all those approaches except keyhole with results which were not optimum always for trigeminal nerve function. So for those tumors, it's not really a question of approach, but keeping trigeminal nerve. I don't know what's your experience all with this tumor, but this is my main concern with schwannoma, trigeminal nerve schwannoma.
Takiyo, would you like to answer or give some input?
Okay, thank you for the question. At first, I would like to ask the question from the Professor Imad. When we start the skull-based approach, Professor Ohata always emphasized to access the origin of the tumor. It means devascularization. Detachment is an important step for resection of the skull-based meningioma, especially. So when we operate the posterior fossa meningioma, our team always consider to access the origin of the tumor at first. So when tumor occupies the petroclival junction, I think the combined transpetrosal approach is the best way to devascularize the tumor. But the problem is a combined transpetrosal approach also very complicated procedure. So we have to sophisticate and minimize the invasion. So I developed the minimum anterior and combined transpetrosal approach. Our concept of the minimum combined transpetrosal approach is very similar that of the Professor Sebastian today present. Just expose the petrous ridge and drill out the petrous ridge is a very useful way to detach the tumor. So if the size is more small, just drill out petrous apex, endoscope is enough. So recently we use the keyhole anterior transpetrosal approach. In case, usually use the anterior microscopic anterior transpetrosal approach. During our surgical experience and cadaver study, to drill out the Kawase triangle, endoscope 3 centimeter surgical corridor is enough to complete the bone work. So I moved to the endoscopic procedure from classical microscopic anterior transpetrosal approach to endoscopic keyhole anterior transpetrosal. But our concept is always same. We access the origin of tumor is our basic concept of the skull-based approach. And another question is Sebastian from the Professor Sebastian. To reject the trigeminal schwannoma, of course, the maximum preservation of normal trigeminal fiber is best way or get good result. So compare the microscopic approach or endoscopic approach. Endoscope can offer more clear view between the tumor capsule and normal neural fiber, even Meckel cave or posterior fossa. So recently I shift the endoscopic keyhole anterior transpetrosal approach to get the clear and wide view between the tumor and the normal trigeminal fiber. I'm not sure the number of the cases is not large. So we explain more case. We have to compare the results, the microscopic approach or endoscopic approach, which is better.
So you are using 3 hands technique?
We use the 4 hands technique. We operate 2 neurosurgeons. Our assistant hold the endoscope, 1 hand, and also insert the another instrument. And I use 2 hands. So totally we use 3 instruments to make the space of the dissection of the tumor. And we need dynamic movement of endoscope. So our assistant hold endoscope, not fixed.
We have Professor Amador from Mexico. I don't know whether he is on and he can unmute himself. Amador?
Yes,
Yeah,
sir.
you want to have an input? You are a well-known endoscopic surgeon from Mexico and known to all of us. You've been on this webinar. If you want to have some input or some feedback.
I'm very pleased to have here these excellent lectures by the Professor Takeo Goto, Professor Froelich, and also from Professor Arraez. I think the endoscope, as clearly was shown, is just an optic tool that can be used to address certain areas of the surgical field that are not available to the axial view of the microscope. I enjoy a lot the Professor Goto approach because in this case he shows us that the gentle dissection of the middle fossa in the Kawasaki triangle opens a wide a window through which he can take out these very large tumors located in the Meckel's cave and even the posterior fossa. Although we are more used to use the microscope, the endoscope gives us a unique perspective of the surgical field, and I think if we have the endoscope, we can use it to have a better surgical result. Concerning to the petroclavian meningiomas, there is some technique that was addressed by some guy in Australia, I don't remember the name, in which he says, okay, in very large tumors, you can come to the transnasal, transclavial approach to decompress the tumor and to relieve the pressure in the brain stem. And then you can go to regular approach to take out the rest of the tumor. I don't know if Professor Sebastian Froelich can tell us about this technique.
I have been using lately the endoscope for some of those tumors. I have done cases for pure clival tumors for a long time, and it's a fantastic indication to come from the nose. And again, I followed also the experience of Takeo. And Takeo, I have tried your technique for jugular tubercle meningioma. And I did few cases, and I have to say it's absolutely fantastic. It's a contralateral nostril approach, drilling the rostrum of the sphenoid, finding median nerve on the opposite side, drilling the pterigosphenoidal suture below lacerum segments. You get to condyle, you get to hypoglossal canal, and just above you have jugular tubercle. It's fantastic because you expose the tumor base and you have the lower cranial nerve lateral to it. So I think in terms of functional outcome for the lower cranial nerve, for those jugular tubercle, lower clivus, petroclival meningioma, I think it's definitely great. I have much less experience than Takeo, but I did few cases recently, and I was very satisfied with it. For the classic big petroclival, I don't think it's good. And because cranial nerve location is usually not so sure. It's tumors that extend laterally it's a completely different tumors. It doesn't make sense to come from the nose. But for those lower petroclival or jugular tubercle or clival, yes, it's great.
I want to join venture between Miguel, Vladimir, and Keki. Keki was trained his fellowship with Professor Sami, and Professor Sami in the early 90s, I think he published a series of an approach, suprameatal approach, and incising the tentorium from below. And I have tried this one several times. It's very helpful in these lesions that they are tentorial in the sense, and they sound like the infrasupra because you approach from above, but along the suprameatal area and inside the tentorium, and he drilled the apex from below. What is your memory about this, Keki? Has he tried before? And any feedback? And Vladimir, Miguel, if you want to have an input, and Sebastian. Unmute yourself, Keki.
Yeah. This was actually, this idea came to Prof. Sami a little later, and he was already more familiar with the regular retrosigmoid. And then it was just simply because of some trigeminal neuromas which he approached, where he found it very automatic to open the suprameatal area, and he landed into the supratentorial space. And this idea he utilized subsequently for other tumors, including the petroclival melangiomas. But it all started, to the best of my knowledge, with the treatment of trigeminal neuromas. Most of them were either lying predominantly in the posterior fossa or half and half. But therefore, since he's a master of the retrosigmoid route, it was very obvious that he would choose that route to climb up to the supratentorial compartment.
Vladimir, you want to have an input on
this? Anything which is in front of the fifth is easy to drill off via supra-infra. Whatever is posterior, it's more difficult, but definitely the tubercle may be drilled, but it's necessary only in a few cases where the piece of the tumor is like behind the corner, that you get a lateral to this, and otherwise it's usually a very tiny piece of the meningioma which is hidden behind the apex. And you can get there easily by drilling, but there are not that many of them because this piece of tumor is usually quite free and it comes out of easily. So drilling is in supra-infra, it's seldom, but definitely not really that difficult.
Yeah.
Can I get back to one question you have posed, Imad, to Takeo? Yes. How do you handle that with 4 hands? Who is holding the endoscope for you? Someone who is very, like your twin or?
A neurosurgeon, he said.
A neurosurgeon, of course, but
first year or last year, yeah.
Yeah.
Takeo?
Okay. We make the endoscopic team. So another guy who can operate the endoscopic surgeon assisted me when we perform the keyhole endoscopic surgery. So another neurosurgeon hold the endoscope and also assist one instrument. So we can use 3 instruments.
Okay, thank you.
Miguel, you would like to have input on the...
Thank you very much. Well, I'm not much familiar with the drilling from the retrosigmoid approach because I think the main indication to me is, let's say, extension of the meningioma inside Meckel's cave.
Right.
You can also consider this approach useful for a small lesion, but taking into account the variety of lesion of the petrous apex, some of them very big, and some of them, as Vladimir said, around the corner. To me, the most appropriate way is the anterior transpetrous approach. We have done some cases through endoscopy, but insofar as the lesion is inside posterior fossa, I think it's difficult to remove that in a safe way. So to me, the most appropriate route is the anterior petrosal approach. And I think that I have to congratulate Professor Goto, because I think I like very much Petrus Apex area, Meckel's Cave, and I think your presentation has been amazing. I'd like to ask you, if I may, my dear moderators, one question, because usually you have to, you know that the rule is just the peeling of the fifth nerve. I saw your videos, I don't see the peeling. Do you need this peeling of the trigeminal ganglion, or you do not need that?
Thank you for your question. After drilling out the petrous apex, I opened the Meckel cave at first, and then peel off the wall of the superior wall of Meckel cave from posterior to anterior. Some meningioma invaded more anteriorly. Of course, we have to peel off and expose the ganglion. But some cases just occupy the Meckel cave. In such situation, no need to completely peel off. Just resect in the Meckel cave. Depend on the extension of the tumor.
Okay, thank you very much.
Professor Albaba with us, Samuel? Because he's an endoscopic surgeon, he left most probably, he's in surgery. Now, I have one question to you, Sebastian. Okay, before you give the question, I'll take one from you first. How you manage...
I wanted to... Yes, sorry, go ahead. Sorry.
A question to you, and Thomas, perhaps you should contribute to this question, and all others. How you manage to salvage the sixth nerve in Dorello canal? I saw you left a tumor on top of the canal, but sometimes this is by the time you want to save it, it's gone. Because if the tumor insertion is there, how you manage this one? Because there is no way of monitoring.
I have to say it's quite tough. The sixth nerve, it's probably the most difficult nerve to preserve after fifths, but it depends. First, you have to look extremely carefully to the images to understand the tumor, the epicenter of the tumor, and this is based on CT scan, hyperostosis, T2 sequences looking at the trabeculation inside the meningioma, and also indirect information from the vascularization. According to this, you can have an understanding of where the sixth nerve is displaced. Most often it's displaced medially, and in those cases, you can find the sixth nerve down and you follow the sixth nerve up. Sometimes it's inside the tumor. I had a case yesterday, the tumor, the sixth was really inside on this superior part of six, and I was lucky to find it, but I could eventually have cut it quite easily. So it's a question of trying to anticipate its position, and also sometimes luck, just being fortunate. The patient is fortunate that I found it. It doesn't mean that the patient doesn't have a six. This morning, this patient had a six, but I preserved the six in this entire length. And because it's a motor nerve, it has a good good recovery in general compared to others. So that's it. Finding the nerve in Dorello's canal directly, I found it always very difficult. So at the level of the brainstem, looking at the epicenter where the six would be displaced, I think is the most important. Monitoring, we do it systematically, and it works. It doesn't always work as you would like, but it works.
What kind of monitoring for? You are talking about the sixth nerve, aren't you?
Sixth nerve, yes.
What kind of monitoring?
We put needles in the ocular muscles.
I see.
On direct simulation.
Oh, okay. All right. Thomas on the phone. Any comment or any question? Ramesh, you have any questions?
The only thing I wanted to ask Chakio is approach to the trigeminal schwannoma. Traditionally, when you have a predominant tumor in the cavernous sinus, we would like to go extradurally. So till you get to the lateral wall, then you can get into the tumor and then do a subscapular dissection. Would you consider that when you do an endoscopic approach? Can you go extradurally rather than subdurally?
At first, I go to the subdurally, but around the Meckel cave, I peel off the dura. So at this part, the surgical procedure same, the epidural procedure or subdural procedure.
Okay.
I had one question for Takeo. Have you tried a keyhole extradural anterior petrosal approach? Because one of the issues with your technique, I would consider, is temporal lobe risk of injury, because it's exposed, because you're working along the temporal lobe. But why not trying to go extradural with kind of targeted peeling, you know, or extensive? You start small and then you peel deeper and deeper. Have you tried this? And why not trying it?
I just do the cadaver study, the keyhole endoscopic epidural approach. But even use the endoscope, we have to dissect the same area, expose V3, and have to cut the middle meningeal artery, and also expose petrous ridge. In such situation, there is no difference between the microscopic approach and the endoscopic approach. When we use the subdural approach, we can preserve the venous structure around V3, V2. So we preserve all venous structure around middle fossa. And just limited drill out the petrous bone can save the surgical time and also decrease the invasiveness of the procedure. But as you mentioned, we have to carefully retract the temporal lobe. So we cover the temporal lobe by the rubber and protect the temporal lobe. But in the endoscope, we not strongly retract the temporal lobe. We can get the panoramic view. So just the gravity retraction is enough. No need the spatula to get to the surgical view. So I tried the two approach, but now I think the subdural is good, the whole endoscopic approach.
You tried in cadaver, it's more stiff in cadaver.
Yeah.
It may work.
Yeah. Takeo, from the view of all the cases you showed, whether surgical or imaging, you were doing this one on the right side. I haven't seen any of the cases you have shown on the left side. You have any question about this one? Are you concerned more on the left side than the right side or the endoscope? I'm expecting less space needed.
No. I also use today I presented the several case left side, so we can use the both side. Not so different.
All right, it seems we kept you long, and I'd like to thank all of you. But before we close, I have first to thank Pablo. He was the one who put the program and communicate with everybody. Of course, he cannot control his presence. Last night was the events, and congratulations from all of you to him. And I'd like to thank Miguel. Miguel has invited all the IANA members to collaborate with the Spanish group in May. We are going to have, I understood, the greatest ever meeting happen in Spain, perhaps in Europe. And I'm thank all of you who is contributing to this meeting. And he was kind enough and generous enough to waive hotel reservation for 3 days for all the participants. And he offered his place for the IANA to be part. Thank you, Miguel, for this. Appreciate it. It's associated with the Juan's meetings, which is a very important meeting. He is the president, and we are expecting a 1 week full of activities. I don't know when we are going to visit the rest of Spain. Most of you will stick to you in Malaga. Well, thanks everybody. Thanks, Amador, for joining us, and everybody, and have a good night.
All the best.
Thank you.
Thank you very
Bye.
much.
Maurice.
Bye.
Thank you, Imad. Thank
Bye,
you.
Maurice. Thank you.
Bye.
Thanks, everybody.
Bye-bye.
Take care. Bye-bye. Moody.